Okay, Section 1, Upper GI and Peptic Ulcers.
Let's start by looking really closely at the esophagus, because this is where modern medical practice heavily clashes with classic textbook traps. For example, if you're asked for the best initial investigation for dysphagia, the answer is upper GI endoscopy with biopsy. Do not fall for the old barium swallow trap. For achalasia, sure, a barium swallow gives that famous bird beak appearance, but the true gold standard, that's esophagomanometry. And for esophageal perforation, please avoid the Boerhaave syndrome trap. The most common cause is actually iatrogenic, usually from a recent endoscopy.
Now, this brings us to a massive, highly debated trap regarding the most common esophageal cancer. You absolutely must read the question stem carefully here. If they ask for the most common cause worldwide, your answer is squamous cell carcinoma. But if the stem specifically mentions Western countries, adenocarcinoma takes the lead. Just don't let them trick you with the geography.
Moving down into the stomach, gastric cancers are overwhelmingly adenocarcinomas, located in the antrum, and they're heavily driven by H. pylori. Speaking of H. pylori, it's also the primary cause of peptic ulcer disease, which leaves NSAIDs as the trap answer for second place. If you come across a benign mesenchymal tumor, you should immediately think GIST, which is c-KIT positive. For ulcer locations, gastric ulcers love the lesser curvature, while duodenal ulcers favor the first part of the duodenum. And you have to beware the deadliest anatomical trap of all. A posterior duodenal ulcer erodes the gastroduodenal artery and bleeds massively. An anterior duodenal ulcer is the one that perforates. Remember that. Posterior bleeds, anterior perforates.
Take a quick moment to mentally shift gears. We've navigated the upper GI tract safely. So what happens when we leave the stomach and enter the midgut? Let's find out.
Section 2, Small Intestine and Appendix.
Let's dive into small bowel obstructions, or SBOs. The most common cause overall is adhesions, especially in developed countries. But here is the tricky part. In many low-resource settings, or even in older exam answer keys, hernias might actually be the correct answer, so read the context carefully. For amecal diverticulum, it famously follows the rule of twos, including being located exactly 2 feet from the ileocecal valve. Notice the demographic trap here as well. In adults, the most common complication is intestinal obstruction, but if your patient is a child, it almost always presents as bleeding. Finally, if an SBO is strangulated, the treatment is emergency surgery. Never ever delay.
And now let's talk about the appendix. The classic trap here relies entirely on the patient's age. In adults, the most common cause of appendicitis is luminal obstruction by a fecalith, but in children, the trap answer you're looking for is lymphoid hyperplasia. When it comes to imaging, a CT of the abdomen is best for adults, but exam writers love to test your safety knowledge, so remember that ultrasound is always your first step in children and pregnant patients. Oh, and the most common position of the appendix? Retrocecal, for sure.
You're doing absolutely fantastic. We are officially halfway through the anatomy. But let me ask you, what are the deadliest traps waiting for us down in the large bowel?
Section 3, Colon, Rectum, and Anorectal.
Here is a totally crucial concept. Colorectal carcinoma is the most common cause of large bowel obstruction in adults, with the sigmoid colon being the most frequent site. But the clinical presentation depends entirely on the anatomy. A right-sided colon cancer presents with anemia due to occult bleeding. A left-sided cancer presents with obstruction due to a much narrower lumen. Also, keep an eye on the tumor marker, CEA. The trap is using it for screening. It's not for screening, it's strictly for follow-up. For staging, use a CE-CT, but remember, MRI is specifically needed for the rectum. Finally, since colon bloat drains right into the portal circulation, the liver is the top metastatic site.
Dropping down to the anorectal area, do not let them confuse you. Anal fissures are acutely painful and are most commonly found at the posterior midline, or the 6 o'clock position. Hemorrhoids, on the other hand, are typically painless and sit at the 3, 7, and 11 o'clock positions. To treat a chronic fissure, the gold standard is a lateral internal sphincterotomy. For fistulas, you really must remember Goodsall's rule to predict the fistula tract. It is highly tested. And for locally advanced rectal cancer, staging requires an MRI of the pelvis, often followed by chemoradiotherapy.
Section 4, IBD and diverticular disease.
Okay, this next comparison is literal exam gold. Crohn's disease versus ulcerative colitis. The absolute biggest trap here? Smoking. Smoking actually worsens Crohn's disease, but it paradoxically protects against ulcerative colitis. Don't let that one slip by you.
Anatomically, Crohn's can happen anywhere from the mouth to the anus, presenting with skip lesions, and it frequently causes fistulas. Ulcerative colitis, however, is continuous, it always starts in the rectum, and it carries the dreaded surgical emergency risk of toxic megacolon.
When a patient comes in with acute diverticulitis, which is usually in the sigmoid colon, here are your steps. Step 1, get a CT of the abdomen. Step 2, and this is the vital exam trap, you must completely avoid a colonoscopy during the acute phase due to the extremely high risk of perforation. Step 3, you wait until they have fully recovered, and then you do the colonoscopy to exclude an underlying malignancy.
Section 5. Hernias and GI bleeding.
Anytime you see a question about GI bleeding, the exam really just wants to know your priorities. At minute 0, you do not rush to diagnose. You start with the ABCs, IV fluids, and blood if needed. Resuscitation always comes before diagnosis. Once the patient is totally stable, usually within 24 hours, then you can proceed to the gold standard upper GI endoscopy.
For bleeding, remember that peptic ulcer disease is the top cause of upper GI bleeds. For lower GI bleeds, it's diverticulosis, but definitely watch out for the angiodysplasia trap in the elderly. Now let's decode hernias. The most common overall is the congenital indirect inguinal hernia, but the highest risk of strangulation, that's the femoral hernia, which is more common in females. For anatomy, just use the inferior epigastric vessels as your main landmark. A direct hernia bulges medial to the vessels through Hasselbalch's triangle, while an indirect hernia goes lateral to enter the deep ring.
Section 6, High-Yield One-Liners. It is time to cement your knowledge with our rapid-fire review. Let's lock these facts in.
Upper GI endoscopy with biopsy is the undisputed gold standard for esophageal and gastric cancers. Achalasia shows a bird beak on a barium swallow, but manometry is the true gold standard. Never forget this one. A posterior duodenal ulcer bleeds, while an anterior duodenal ulcer perforates. Adhesions are the most common cause of small bowel obstructions in adults. The appendix is most commonly retrocegal, and colorectal cancer is the most common cause of large bowel obstruction in adults.
Continuing our rapid-fire review, CEA is strictly for colorectal cancer follow-up. It is not for screening. The liver is the most common site for colorectal cancer metastasis. The posterior midline is the classic site for a painfully acute anal fissure. Crohn's disease means skip lesions and fistulas, while ulcerative colitis means continuous inflammation starting right at the rectum. Peptic ulcer disease is the #1 cause of upper GI bleeding. And finally, the indirect inguinal hernia is the most common, but the femoral hernia has the highest risk of strangulation.
Okay, let's dive into this. Section 1, gallbladder and biliary tract, stones, colic, and carcinoma. Now, take a look at this high-yield table. When a question asks for the most common type of gallstone, you're looking for cholesterol stones. Pigment stones are way less common. But here's a classic trap. What is the most common presentation of gallstones? It is biliary colic, not acute cholecystitis. Most patients just experience the pain of colic. Now, if it actually does progress to acute cholecystitis, examiners absolutely love testing the organism. You might see Klebsiella or Enterococcus as options, but E. coli is your prime culprit. Go with E. coli. Also, watch the timeline in the question stem. Complications like empyema, gangrene, or perforation happen if the disease is left untreated for a while, so read carefully. Oh, and a positive Murphy sign? That's your gold star indicator for acute cholecystitis.
So the crucial point is that phrasing is literally everything on these exams. If a question asks for the first-line investigation of choice, you want an ultrasound of the abdomen. But if they shift gears and ask for the gold standard treatment, the answer is surgical removal, specifically a laparoscopic cholecystectomy. A super common trap is throwing in medical therapy as an option for symptomatic stones. Don't fall for it. The gold standard is absolutely surgical removal.
Now, what happens when that stone escapes the gallbladder and gets lodged in the common bile duct? This is choledocholithiasis. The clinical flow here is incredibly testable. The investigation of choice, meaning your best diagnostic tool, is an MRCP. But the gold standard treatment, that's an ERCP followed by a cholecystectomy. Think of it like this. MRCP is diagnostic, ERCP is primarily therapeutic. Now, if a patient presents with obstructive jaundice, your best initial test is still an ultrasound first. You only move to that MRCP if you suspect common bile duct pathology based on what you saw in the ultrasound.
Before we leave the gallbladder, let's touch on gallbladder carcinoma. Over 90% of these are adenocarcinomas. The absolute most important risk factor you need to scan for in the vignette is a history of gallstones, especially large ones. And anatomically, examiners love to test the most common site for this carcinoma to develop. It's the fundus of the gallbladder. Lock that detail away in your brain.
Doing great so far. Section 2, obstructive jaundice and cholangitis, defining the triads and pentads. This slide directly addresses a highly debated MCQ. What is the most common cause of obstructive jaundice? Well, you have to read the question stem incredibly carefully. If they ask for the most common cause overall, which implies a benign cause, the answer is a common bile duct stone. But if they specifically ask for a malignant cause, don't jump to cholangiocarcinoma. The correct answer is actually carcinoma of the head of the pancreas. When an obstruction leads to an infection, we get acute cholangitis. And you absolutely must know the classic presentation known as the Charcot triad. It's fever, jaundice, and right upper quadrant pain. When you see this specific triad in a patient vignette, acute cholangitis needs to be at the very top of your differential diagnosis. It's your baseline indicator.
Let's move to and see how this builds when the patient's condition starts deteriorating. If the infection becomes severe and systemic, the Charcot triad evolves into Reynolds pentad. That's the original triad, fever, jaundice, and RUK pain, plus hypotension and confusion. Adding shock and altered mental status means this is severe, life-threatening disease requiring urgent intervention.
So how do we treat this severe infection? Just like with cholecystitis, the most common organism is E. coli. Other gram-negative enteric bacteria play a role, sure, but E. coli is the star of the show. The biggest exam trap here involves the treatment. While you will absolutely give these patients IV antibiotics, the definitive treatment is urgent biliary drainage, typically via ERCP. Choosing antibiotics alone on a test for severe cholangitis is going to cost you points. You simply have to relieve the obstruction.
All right, Section 3, liver infections and cysts. Amoebic versus pyogenic.
Here is a classic geography trap examiners love to use. If a question asks for the most common liver abscess worldwide or places the patient in an endemic area, the answer is an amoebic abscess. However, if the vignette describes a patient in a developed, urban country, it's a pyogenic abscess, most commonly caused by, yep, you guessed it, E. coli. You really have to strictly follow the wording of the question regarding the patient's location. The management of these two abscess types is also a super frequent trap. For both, the initial investigation of choice is an ultrasound, though a CT can be used for more complex cases. But look at the treatment difference here. For a pyogenic abscess, the gold standard is antibiotics plus percutaneous drainage, especially for larger abscesses. But for an amoebic abscess, the treatment is primarily medical. Use the drug metronidazole. You really only drain an amoebic abscess if it's strictly indicated, like if it's at high risk of rupturing.
Next up is the hydatid cyst. For some reason, board examiners have this absolute obsession with the dog tapeworm, Echinococcus granulosus. Honestly, you'd think the exam writers are all cat people or something. Just remember that this organism most commonly targets the liver, though the lung is the second most common site. Again, ultrasound is your primary diagnostic tool. And for medical management, which is often used as an adjunct to surgery, the drug of choice is albendazole.
Keep that steady pace, you're doing great. Section 4, malignancies and portal hypertension, primary versus secondary disease.
Now, what's really interesting about this slide is how easily our brains just sort of skip over adjectives when we're stressed. If they ask for the most common primary liver cancer, the answer is hepatocellular carcinoma, or HCC. But if the question asks for the most common liver malignancy overall, the answer is metastasis. The liver filters blood from all over the body, so it's a prime target for secondary tumors. Don't reflexively click HCC without reading the word primary first.
When it comes to HCC, the highest yield tumor marker you gotta know is AFP, or alpha-fetoprotein. And there's another geography trap here regarding risk factors. Worldwide, the major risk factor for HCC is chronic hepatitis B. But in Western populations, cirrhosis, often due to hepatitis C or alcohol, is the major cause. Speaking of cirrhosis, it is unequivocally the most common cause of portal hypertension worldwide. The most dangerous, life-threatening complication of that portal hypertension is a variceal bleed. Examiners will test your exact sequence of management here. Do not jump straight to surgery or endoscopy. Step 1 is always resuscitation and stabilizing the patient. Step 2 is administering a vasoactive drug. Only once the patient is stabilized, you move to step 3, which is urgent endoscopy. And when they ask for the definitive endoscopic treatment of choice, choose band ligation. It's highly preferred over sclerotherapy. We've made it to our final section, Section 5, liver trauma and synthetic function, critical care and labs.
Trauma questions have a really classic trick.
If the vignette asks for the most commonly injured solid organ overall in blunt abdominal trauma, the answer is the spleen. However, if they describe a penetrating injury, the liver actually becomes the most commonly injured abdominal organ.
When investigating these trauma patients, their hemodynamics dictate your answer. A stable patient has the time to go to the scanner, so the gold standard investigation is a contrast-enhanced CT of the abdomen. But if the patient is unstable, hypotensive, crashing, you can't send them to the CT scanner. They require an immediate fast ultrasound scan right at the bedside.
And this brilliantly illustrates how we break down liver labs. When they want the best indicator of acute hepatic synthetic function, meaning how well is the liver actually making things right now, choose INR or prothrombin time. Albumin takes too long to drop, so it really reflects chronic function. For cholestasis or biliary obstruction, you want ALP and GGT, not your transaminases. And if they ask for the most sensitive marker of actual hepatocellular injury, choose ALT. It's way more specific to the liver than AST.
Section 1, Embryology and Anatomy. To really understand thyroid anomalies, you've got to picture how the gland actually develops. Right around week 3, it originates at the foramen cecum, basically the base of the tongue. Then, from weeks 4 to 7, it travels all the way down through the thyroglossal duct, finally reaching its home in the neck from week 7 onwards. This little embryological journey is super high yield because it perfectly sets up our very first clinical scenario. Because of that descent we just talked about, the most common congenital anomaly you'll see is a thyroglossal duct cyst. Clinically, you'll spot this because it uniquely moves when the patient swallows or sticks out their tongue. Now here is the trap. The test writers will absolutely try to tempt you with simple excision as the treatment. Don't fall for it. The correct answer is the cyst trunk operation. You have to take out the cyst, the middle portion of the hyoid bone, and the entire duct tract. If you just do a simple excision, the recurrence rate is incredibly high. Moving right along to Section 2, Thyroid Nodules and Cancers. Okay, so a patient comes in with a swollen thyroid and naturally anxiety is high. It's really easy to jump straight to the worst case scenario. But do not fall for the exam trap of immediately assuming every mass is cancer. Purely statistically, the absolute most common cause of a thyroid swelling is just a benign colloid or multinodular diter. And if they ask you about the most common solitary nodule, same deal. Most are entirely benign colloid nodules. Always think benign before malignant when you're looking at the raw statistics. But of course, sometimes it is cancer, and you absolutely need to know how to tell them apart. Let's break down the big 4. Papillary carcinoma is your most common. We're talking 80 to 85% of cases. It's the one most often seen in children or after radiation, and crucially, it spreads through the lymphatics. Now, contrast that with follicular carcinoma. That one spreads hematogenously, meaning through the blood, often heading straight to the bones and lungs. Then you have medullary carcinoma, which is uniquely tied to Mentu syndrome and the RET mutation. And finally, anaplastic. You'll recognize this one because it's highly aggressive and, unfortunately, has a very poor prognosis. Speaking of medullary carcinoma, there is a very specific trick they love to pull regarding where this cancer actually comes from. Medullary arises from the parafollicular C cells, not the follicular cells. And it secretes calcitonin, which is exactly what we use as its tumor marker. The exam trap? They'll try to tempt you with follicular cells, or maybe throw in CEA as the primary marker. Ignore that. Lock in C cells and calcitonin and you'll be golden. Next up, Section 3, Investigations and Definitive Diagnosis. So, how do we actually investigate these nodules without getting tripped up by outdated guidelines? Well, the modern diagnostic workflow starts with a TSH level and a neck ultrasound, period. Older questions might try to beat you into jumping straight to an unguided fine needle aspiration right off the bat. Skip that trap. The correct sequence today is TSH and ultrasound first. Then, if the scan indicates it, you do an ultrasound-guided FNA. And finally, if needed, you get the histopathology of the actual surgical specimen. And speaking of FNAC, we really need to talk about its biggest blind spot. Yes, it's the gold standard for most nodules, but it completely fails when it comes to distinguishing a benign follicular adenoma from a malignant follicular carcinoma. Why? Because diagnosing that carcinoma requires seeing actual capsular or vascular invasion. A tiny needle biopsy just can't show you that architecture. You absolutely need a surgical histopathology specimen for a definitive diagnosis. If you pick FNAC alone for follicular neoplasm, you've fallen right into the trap. There are also a couple of specific anatomical situations you should watch out for. If your patient has a retrosternal goiter, meaning it's growing down into their chest, you need a CT scan of the neck and chest to clearly map out how far down it goes. Also, before you ever take a patient to thyroid surgery, you really need to evaluate their vocal cord function with an indirect or flexible laryngoscopy. You're operating right next to some incredibly delicate nerves, so establishing that baseline beforehand is absolutely critical.
All right, Section 4, Hyperthyroidism and Thyroid Storm.
Let's talk about Graves' disease. It's an autoimmune condition and the absolute most common cause of hyperthyroidism. When an exam asks for the most specific antibody for Graves, they will almost always dangle anti-TPO in front of you as a distractor. Don't take the bait. The most specific antibody actually driving the disease is the TSH receptor antibody. You'll usually see this written out as TRAB or TSI. Now, what if that hyperthyroidism spirals out of control into a life-threatening thyroid storm? You have to follow a very strict timeline here. At minute 0, your immediate first move is giving the antithyroid drug PTU, along with a beta blocker like propranolol. This powerful combo does two things. It stops new hormone from being made, and it stops T4 from converting to the more active T3 in the body. Then, and this is crucial, you wait. You have to wait at least 1 hour before giving iodine. The classic trap is giving iodine first. If you do that before the PTU has kicked in, you're literally just giving the thyroid more fuel to make even more hormone. When we look at these antithyroid meds overall, context is everything. For standard, run-of-the-mill hyperthyroidism, methimazole or carbamazole are your go-to first-line drugs. But examiners want to know if you understand the exceptions. You strictly use PTU in 2 major scenarios: during that acute thyroid storm we just talked about, and during the first trimester of pregnancy. Keep those straight and you'll nail these questions. Finally, let's wrap up with Section 5, surgery and postoperative complications. Before we even get to the OR, remember your patient must be rendered euthyroid first to keep the surgical risk low. Once you're actually operating, say for a papillary carcinoma, watch out for this trap. Older guidelines used to push for a total thyroidectomy for pretty much everyone. Because of that, older exam questions might expect that answer. But modern guidelines tell us that for small, low-risk tumors, a simpler hemithyroidectomy is perfectly fine. Always, always double-check the size and risk profile in the question stem before you answer. After surgery, your main job is monitoring for nerve injuries, and these are heavily tested. The recurrent laryngeal nerve is the big one. If it's injured on just one side, the patient will have distinct voice changes. This is the complication surgeons fear the absolute most. But if it's injured bilaterally, that's a massive emergency. It causes airway obstruction, and you might be looking at an immediate tracheostomy. On the other hand, if the external branch of the superior laryngeal nerve gets nicked, the presentation is much more subtle. They'll lose their high-pitched voice. You might only really notice it if the patient is a singer, but it's devastating for them. So nerve injuries are the most feared. But are they the most common? Actually, no. The most frequent complication you'll see after a thyroidectomy is transient hypocalcemia. The parathyroid glands often get a little stunned or dysfunctional during the procedure. The trap here is instinctively clicking on nerve injury when they ask for the most common complication. Don't do it. The right answer is transient hypocalcemia, which is exactly why we monitor post-op calcium levels so meticulously.
Speaking of the parathyroids, if a patient comes in with primary hyperparathyroidism, the most common culprit, we're talking 80 to 85% of the time, is just a single parathyroid adenoma, not hyperplasia. Hyperplasia is a trap. When you need to find this adenoma before taking them to surgery, a Cesta-BB scan is your best bet. And we usually pair that up with an ultrasound for the best localization. All right, let's bring it all together and rapidly consolidate what we've learned so it really sticks. Papillary is the most common cancer, and it spreads via lymphatics. Follicular spreads through the blood to bones and lungs, and remember, FNA cannot tell an adenoma from a carcinoma. Medullary comes from C cells and secretes calcitonin, while anaplastic is the aggressive one. For nodules, always start with TSH and ultrasound. Graves is the most common hyperthyroid cause, but use PTU if they're in a storm or their first trimester. For complications, transient hypocalcemia happens the most, while recurrent laryngeal nerve injury is feared the most. And lastly, that thyroglossal duct cyst, it moves when they swallow, and you treat it with the cyst trunk procedure. Read these over and confidently lock them into your memory.
Question 1. Diagnosing the breast lump and the initial assessment. So, the initial assessment of a patient presenting with a mass is absolutely foundational, and memorizing this exact sequence is incredibly high yield. It's the gold standard approach known as the triple assessment. If a question asks for the best initial approach, it is always these 3 steps in this exact order: clinical examination, followed by imaging, followed by a biopsy. You know, sometimes it's tempting to jump the gun, but do not skip straight to imaging or biopsy.
It is a completely non-negotiable sequence.
Okay, let's talk imaging, because this is where a classic exam trap pops up based on the patient's age. For a patient under 30 years old, the correct answer is always an ultrasound. Why? Well, younger women have denser breast tissue, which shows up white on a mammogram, totally obscuring potential tumors. Now, for patients over 40, mammography is your first line, though an ultrasound can be added if needed. If you have a high-risk patient, like someone with a BRCA mutation, a breast MRI is the way to go. Also, keep an eye out for the classic cancer-finding examiners want you to recognize, a spiculated mass with microcalcifications. If you see those exact words in a vignette, you need to think malignancy right away.
Right, so once imaging is done, we need a tissue diagnosis. And here is a massive, and I mean massive, exam trap. Choosing FNA-C, which is fine needle aspiration cytology, over a core needle biopsy. The crucial thing to remember here is that a core biopsy is the gold standard because it provides histopathology. That means it actually preserves the tissue architecture. And that's absolutely crucial because it allows the pathologist to see if the cancer cells have invaded the basement membrane. FNA, on the other hand, only provides cytology. It's basically just a smear of cells, meaning it literally cannot assess for invasion. So always pick core biopsy.
Moving right along to Section 2, Benign Tumors and Conditions.
I really want you to pay close attention here because question writers love to play semantic games with the vocabulary in this section. If they ask you for the most common benign breast disease, the correct answer is fibrocystic change. But if they ask for the most common benign breast tumor, the answer is fibroadenoma. Don't read the question too fast and step on this vocabulary mine. Remember, disease equals fibrocystic, tumor equals fibroadenoma.
Let's zoom in on that fibroadenoma for a second. These typically show up in younger women, usually aged 15 to 35. The clinical vignette will almost always describe a mobile, firm, and painless lump. In fact, it's so mobile that the classic exam buzzword is the breast mouse, because it just kind of slips away under the examining fingers. And here is the management trap. Not all of them actually require surgery. If it's a typical presentation and the patient is young, simple observation is perfectly acceptable. You really only excise it if it's large, actively growing, or causing symptoms.
Okay, Section 3, Breast Cancer Essentials and Malignant Pathologies.
Let's just methodically lay out some essential oncological facts, starting with the most commons. The most common histological type is invasive ductal carcinoma, no special type, which accounts for about 70 to 80% of all cases. The most common site? That'd be the upper outer quadrant, which includes the axillary tail. Now, the most common presentation is a painless breast lump. Students so often fall into the trap of thinking cancer always hurts. Usually, early breast cancer just doesn't. The most common site for distant metastasis is the bone, though the lung and liver are also pretty frequent. And finally, the universal, best staging system is TNM.
Quick pause here. I want you to think about your answer to this question. What is the most important prognostic factor in localized breast cancer?
Did you say molecular subtype? Or maybe axillary node status? You know, this is actually a highly debatable area in modern clinical practice. But remember, we are focusing on passing your exams right now. While modern oncology relies heavily on molecular subtypes for prognosis and targeted treatment, for board exams regarding non-metastatic disease, the classic, unshakable correct answer remains axillary lymph node status. It is absolutely the highest yield prognostic indicator they're going to look for.
Next up, Section 4, Navigating the Axilla and Surgical Management.
So the surgical management of the axilla is an area where evolving clinical guidelines frequently confuse test takers. If a patient is clinically node negative, meaning you literally don't feel any enlarged nodes on exam, the standard of care is a sentinel lymph node biopsy. We just do not do routine axillary clearance anymore. That's an old trap. But what if that sentinel node actually comes back positive? Well, older exams would automatically point you straight to axillary clearance, but modern practice and current exams recognize that further management depends heavily on tumor characteristics, the type of surgery planned, and the exact number of positive nodes. So be very, very cautious if axillary dissection is listed as an option. It's just not the automatic next step it used to be.
All right, on to Section 5, Surgery, Tumor Markers, and Targeted Therapies. When you're looking at surgical options, pay close attention to absolute pairings. For instance, breast-conserving surgery, like a lumpectomy, must be followed by postoperative radiation. They are a total package deal. Because of that, an absolute contraindication to breast conservation is the inability to receive radiation, say if the patient is pregnant or has a prior history of chest radiation.
Another strict contraindication is persistent positive margins. Now, if conservation just isn't possible, a modified radical mastectomy is done. And a quick anatomy reminder, the modified part means it preserves the pectoralis major muscle, totally unlike the archaic house-stamp radical mastectomy.
Now, tumor markers literally dictate systemic therapy. For ER-positive cancers, you give tamoxifen if the patient is premenopausal, but an aromatase inhibitor if they're postmenopausal. For HER2-positive tumors, the targeted therapy is trastuzumab. But here is the major trap. Trastuzumab is cardiotoxic, so you absolutely must select the option that includes checking cardiac function with an echo. Finally, triple-negative breast cancer lacks all these receptors, so there is no targeted hormone or HER2 therapy available for them. They just receive chemotherapy.
Finally, Section 6, Infections, Special Diseases, and Unique Vignettes.
Let's talk infections. The most common cause of lactational mastitis is Staphylococcus aureus, and the massive exam trap here is the management. Whatever you do, do not stop breastfeeding. You must advise the mother to continue breastfeeding or pumping to clear those milk ducts. If a breast abscess has already formed, antibiotics alone just won't cut it. You have to select incision and drainage or aspiration plus antibiotics. And if you ever see a non-lactational recurrent abscess, especially in a patient who smokes, you need to consider periductal mastitis, but always rule out underlying malignancy first.
This next one is a classic, highly tested physical finding, peau d'orange, which literally translates to orange peel. It happens due to lymphatic obstruction by breast cancer cells right in the skin, causing this edema that makes the hair follicles look exactly like the dimples on an orange. If you see this described in a vignette, it definitively indicates locally advanced breast cancer.
To wrap up the specific diseases, let's contrast two really visually distinct nipple presentations. Bloody nipple discharge is most commonly caused by a benign intraductal papilloma. However, if you see an eczematous, itchy, scaling lesion right on the nipple, that is a classic hallmark of Paget's disease of the breast. The crucial takeaway for you here is that Paget disease strongly implies an underlying breast carcinoma. It's not just some simple skin condition.
Okay, let's lock all this in with a rapid-fire mental reinforcement. Ready? Fibrocystic change is the most common disease. Fibroadenoma is the most common tumor. Invasive ductal carcinoma is the most common cancer, usually found in the upper outer quadrant. Always prefer a core biopsy over FNAC for tissue diagnosis. Axillary node status remains your top prognostic factor on exams. Bone is the most common metastasis site. Sentinel node biopsy is the standard for clinically node-negative axilla. And breast-conserving surgery always requires postoperative radiotherapy.
All right, let's dive right in. Section 1, the kidneys. This is an absolute prime location for diagnostic traps, especially when it comes to stones and carcinoma. When evaluating renal stones, examiners absolutely love to test your knowledge of microscopy and pH. Take calcium oxalate, for example. It's the most common stone overall, but the trap? People forget its presentation. It's radial opaque, meaning it lights up bright on an X-ray, and it has these classic envelope-shaped crystals. Now contrast that with struvite, or magnesium ammonium phosphate. This is the most common cause of a massive staghorn calculus. But the exam trap here is actually microbiological. The test writers will specifically link struvite stones to urease-producing bacteria, like Proteus mirabilis. That bacteria splits urea, which creates an alkaline urine environment. Understanding that exact chain of events is how you secure your points. Now, interestingly, some stones just don't play by the standard imaging rules. You need to be super cautious if an exam question describes a patient with classic kidney stone symptoms like severe flank pain, but then gives them a completely normal, negative, plain X-ray. Why? Because uric acid stones are famously radiolucent. They simply won't show up on that X-ray. The clue will actually be in the urinalysis, where you'll see rhomboid crystals in acidic urine. On the flip side, if you see hexagonal crystals mentioned, boom, immediately think of cystine stones, which are strongly tied to the genetic condition cystinuria. Let's lock in your clinical protocols and diagnostic hierarchy. If a patient shows up with hematuria, your very first step is always a simple urinalysis. But to actually confirm and visualize the stones, a non-contrast CT-KUB is your gold standard. Here's the trap, though. If your patient is pregnant, radiation is an absolute no-go. You have to pivot immediately and select an ultrasound instead. As for treatment, if a ureteric stone is less than 10 millimeters, the best approach is conservative. The exam is definitely going to tempt you with surgical options, but don't take the bait. Hydration, analgesia, and maybe some tamsulosin are usually all you need, since most of these will pass on their own. Shifting gears to malignancy, let's talk about renal cell carcinoma, the most common adult kidney cancer, specifically the clear cell subtype. The most dangerous trap here is the infamous classic triad of hematuria, flank pain, and a palpable mass. Textbooks talk about it constantly, but do not wait for it to make your diagnosis. In reality, it shows up in a tiny minority of patients. Instead, you need to watch for paraneoplastic clues. Since the kidney produces EPO, an RCC can cause polycythemia, or super high red blood cell count. It can also cause hypercalcemia. If you suspect it, your go-to investigation is a contrast-enhanced CT of the abdomen for staging. And always, always check for metastases to the bones and lungs. Moving smoothly down our anatomical pathway, we hit section 2, the prostate and bladder. Let's look at anatomy, obstructions, and malignancy. Okay, this next anatomical distinction is quite literally one of the highest yield one-liners you can memorize. Benign prostatic hyperplasia, or BPH, arises in the inner transition zone of the prostate. Because it's central, it compresses the urethra and causes urinary symptoms pretty early on. On the other hand, prostate cancer most commonly arises in the outer peripheral zone. Since it's on the edge, you can feel it during a physical exam, but it often won't cause urinary symptoms until it's really advanced. Let's look a bit closer at BPH. As the most common cause of bladder outlet obstruction in elderly men, you are going to see this on your exams all the time. When investigating, you'd order a urinalysis, maybe a PSA, and an ultrasound. But the trap? Omitting the physical exam. A digital rectal exam, a DRE, is absolutely essential and has to be part of your correct answer. When it comes to surgery, a TURP is the gold standard. But again, watch out for the trap, offering a TURP way too early. It's only indicated for moderate to severe symptoms that haven't responded to medication. And speaking of TURP, the complications are an absolute minefield. This is a brilliant example of the difference between what's most common and what's most highly tested. If a patient who just had a TURP suddenly becomes confused, agitated, or starts seizing, you have to immediately suspect TURP syndrome. What happens is the irrigation fluid from the surgery gets absorbed systemically, diluting the blood and causing dilutional hyponatremia, which is dangerously low sodium. Now, TURP syndrome is a heavy-hitting, highly tested emergency, but retrograde ejaculation, that's actually the most common routine complication. You need to know both, but more importantly, you need to know how differently they present. All right, let's step through the diagnostic pathway for prostate cancer. Initial screening is usually a PSA blood test combined with a DRE. But remember, those don't confirm cancer. The definitive, absolute gold standard for diagnosis is the prostate biopsy, often trust-guided or transperineal, because only histopathology can truly confirm it. Once it's confirmed, where are you looking next? Well, prostate cancer loves to travel to the bones, specifically presenting as osteoblastic or bone-forming lesions in the spine. So if an elderly man with urinary symptoms suddenly complains of severe back pain, your alarm bells for metastasis should be ringing loud and clear. Moving on to the bladder. Listen, the single most critical association you need to cement in your mind right now is this: painless hematuria equals bladder cancer until proven otherwise. If there's blood in the urine but no pain, it's probably not an infection or a stone. You have to suspect malignancy. The most common type is urothelial carcinoma. And for diagnosis, the gold standard is a cystoscopy with a biopsy. The exam trap is going to try to offer you urine cytology as the definitive test. Don't fall for it. Cytology is just supportive. You absolutely need the direct visualization and tissue sample that only a cystoscopy can provide. Before we move down from the bladder, we have to hit a classic pharmacology crossover. Hemorrhagic cystitis is a severe bladder inflammation that presents with bleeding. Test writers love to see if you know its classic cause, the chemo drug cyclophosphamide. If a question mentions a patient on cyclophosphamide who gets hematuria, the trap isn't just knowing the diagnosis, it's knowing how to prevent it. You have to know to co-administer the protective agent Mesna to stop that toxic metabolite from destroying the bladder wall. Let's continue our descent. Section 3. Testicles and scrotal diseases. This is where diagnostic speed and knowing your tumor markers will make or break your score. Let's break down testicular tumors. You've got two main categories: seminomas and non-seminomatous germ cell tumors. Seminomas are the most common, and luckily, they have the best prognosis because they are super sensitive to radiation. But here is the ultimate exam trap: the tumor markers. In a pure seminoma, beta-HCG might be a little elevated, but AFP, alpha-fetoprotein, is always normal, literally always. So if a question describes a testicular mass and explicitly points out an elevated AFP, that guarantees it is not a pure seminoma. It strongly points to a non-seminomatous tumor, which unfortunately carries a much worse prognosis. Now let's look at how risk evolves over a patient's life with an undescended testis, or cryptorchidism. Timing is everything. The corrective surgery, or chiopexy, needs to happen early, ideally between 6 and 18 months. Doing this protects the testicle's temperature regulation and preserves fertility, because infertility is actually the most common complication overall. But the major trap here is about adulthood. You have to remember that even with early, successful surgery, the patient's lifelong risk of developing a seminoma stays elevated compared to the general population. The surgery helps with monitoring and fertility, but it does not erase that cancer risk. Benign scrotal masses can be super tricky. A hydrocele, which is fluid around the testicle, will have positive transillumination. Basically, a light shines right through it, which safely tells you it's not a solid tumor. A varicocele, which famously feels like a bag of worms, is most common on the left side because the left gonadal vein drains at a right angle straight into the left renal vein. But here is a massive red flag exam trap. If you see a sudden onset varicocele or a right-sided varicocele, especially in an older guy or one that doesn't go away when he lies down, you need to immediately suspect a renal cell carcinoma that's invaded the renal vein and blocked the drainage. Okay, this next rule is non-negotiable. An acute, painful scrotum in a young male is testicular torsion until proven otherwise. The blood supply is literally twisting and dying. The classic exam trap is going to offer you an ultrasound to confirm the diagnosis. Do not pick it. If your clinical suspicion is high, you pick immediate surgical exploration. Every single minute counts here. Delaying for imaging will cost the patient their testicle, and it will cost you your points.
We're wrapping up the anatomy at the urethra, section 4. This is highly tested in emergency trauma scenarios, especially with severe pelvic fractures.
In any trauma scenario, if a patient has a pelvic fracture and you spot even a single drop of blood at the urethral meatus, stop. The test raters are watching closely to see if you're going to severely injure this patient by blindly passing a Foley catheter through a torn urethra, which could create a false passage and make things way worse. The protocol is crystal clear. Under no circumstances do you pass a Foley. You must always perform a retrograde urethrogram, or RUG, first. This lets you visualize the anatomy and make sure the urethra is completely intact before you even think about catheterization. Finally, section 5. Let's review a few highly debated topics where hospital protocols are actually shifting, and then we'll do a rapid-fire summary of the absolute must-know one-liners.
Here's a bit of an insider tip. You have to be incredibly careful with debatable questions, mostly because textbooks sometimes lag behind real-world modern practice. For example, in real life, medicine is shifting toward doing an MRI before a prostate biopsy. But legacy exam questions, they often still expect you to pick the TRUST biopsy directly as the gold standard. For your Reederich stones, remember there's no single magic bullet. Treatment truly depends on size, location, and whether there's an infection. And for gross, painless hematuria, don't just lazily pick an ultrasound. The comprehensive, correct approach demands a cystoscopy for the bladder plus upper tract imaging like a CT.
All right, let's cement all of this with a rapid-fire review of high-yield one-liners to instantly secure your points. Ready? Calcium oxalate is the most common. Struvite means Proteus. CTKUB is for stones. BPH is in the transition zone. Cancer is in the peripheral zone. TERP is for symptomatic BPH. Retrograde ejaculation is the most common complication, but TUR syndrome means dilutional hyponatremia. Painless hematuria equals bladder cancer, and cystoscopy is your gold standard. And last but not least, blood at the meatus absolutely demands a retrograde urethrogram. Knowing these rules intimately is going to help you effortlessly sidestep those cleverly designed distractors.
All right, section 1. Airway, larynx, and neck. Let's step right around those common pitfalls.
Okay, let's dive right into this. Whenever you see a question about a tracheostomy, the examiner is testing your ability to read the clinical context. So for an emergency tracheostomy, the correct answer is upper airway obstruction. Don't fall for the trap of choosing prolonged mechanical ventilation, because that's the indication for an elective tracheostomy, like you'd see in ICU patients. Now, if they ask for the best emergency surgical airway, you want to go with cricothyrotomy. Why? Because it's literally just so much faster than a standard tracheostomy. As for complications, your main worry early on is bleeding, though they might try to trick you with tube displacement. But for a late complication, tracheal stenosis is the highly tested correct answer for sure.
Moving down to the larynx, squamous cell carcinoma, or SCC, is the most common cancer, and it's highly linked to smoking. The most common site for this is the glottis, which is actually good news since it has the best prognosis. The classic presentation you'll spot in a vignette is persistent hoarseness for more than 3 weeks, and this perfectly sets up how examiners love to test anatomy through foreign bodies. The most common spot for an esophageal foreign body to get stuck is the cricopharyngeus muscle. But if it's an aspirated bronchial foreign body, it's going to be the right main bronchus, simply because it's wider and more vertical. For investigations, an X-ray is your go-to if the object is radiopaque, but if you're still suspicious, endoscopy is the way to go.
Let's calmly look at these neck masses.
You absolutely need to be able to contrast these two congenital cysts clinically. A thyroglossal duct cyst is going to be described as a midline neck swelling, and classically, it moves when the patient sticks their tongue out. The huge trap here is the treatment. It is not a simple excision. The right answer is the Sistrunk procedure. On the flip side, if a vignette describes a lateral congenital neck swelling right along the anterior SCM, you're dealing with a branchial cyst. So midline versus lateral, keep that distinction crystal clear. Section 2, Epistaxis and Tonsillectomy. Let's look at a couple of the most common ENT presentations you'll see. When it comes to epistaxis, or nosebleeds, precision is absolutely key. If they ask for the most common site, Little's area is the undisputed favorite exam answer. The trap they'll set is anterior septum, which, is technically true, but it's just not specific enough for the boards. Now, for posterior epistaxis, which can cause some really severe bleeding, the correct answer for the most common source artery is the sphenopalatine artery. Now, when they test your clinical management of a nosebleed, you have to follow the steps in exact order. Step 1 is always direct pressure, combined with a topical vasoconstrictor. The examiner is definitely going to try to trap you by offering immediate packing as an option. Resist it. Direct pressure always comes first. If the patient has a refractory posterior epistaxis that just will not stop, step 2, the modern definitive treatment, is endoscopic sphenopalatine artery ligation. All right, on to tonsillectomies. The most common indication overall is recurrent tonsillitis. Now, while the Paradise criteria are used to define this strictly, recurrent tonsillitis is the overarching correct answer you're looking for. The most common complication to watch out for is postoperative hemorrhage, but examiners aren't going to just stop there. They want to know exactly when that hemorrhage is happening. So mapping this onto a timeline really helps visualize the risks. Day 0 is the operation itself. If bleeding happens within the first 24 hours, we call that a primary hemorrhage. But here's the classic exam trap, secondary hemorrhage. This predictably happens 5 to 10 days post-op. Why? Because that's exactly when the eschar or scab separates from the tonsillar bed. Lock that 5 to 10 day window in your brain, it's super important. Moving on to section 3, oral cavity and glands. These patterns show up constantly, and they're honestly pretty easy to master. Let's systematically break down the salivary glands. The most commonly affected gland, seeing about 80% of tumors, is the parotid gland. And the most common tumor overall? That's the pleomorphic adenoma, which is benign. But watch out, if the question asks for the most common malignant tumor, your answer shifts to mucoepidermal carcinoma. Also, during any parotid surgery, a classic multiple choice question will ask which nerve is at risk, and that is for sure the facial nerve. Inside the oral cavity, you really need to differentiate between two premalignant lesions. Leukoplakia is a very common white patch. Erythroplakia, on the other hand, is a red lesion. So here's the crucial takeaway. While leukoplakia is way more common, erythroplakia has the highest malignant potential. It is significantly more dangerous. Examiners love to trap students who just quickly click the most common name they recognize, so don't fall for it. Okay, let's talk about Ludwig's angina. This is a rapidly spreading submandibular space infection, usually starting from a lower molar tooth infection. Because it has a dental origin, you might be tempted to jump straight into treating the infection. But remember, this is a massive airway emergency. Step 1, your absolute top priority, is to secure the airway. Only after the airway is completely safe do you move to step 2, which is drainage. Section 4, trauma and cleft palate. Let's keep a clear, logical approach to navigate these surgical topics. Let's break down the most common fracture sites you'll see. For a mandibular fracture, the condylar process is generally the most common site tested. For the midface, it's the zygomatic complex. And the most common facial fracture overall, that's the nasal bone. Now, the huge trap here is the imaging. If you suspect these fractures, relying on a plain X-ray is a trap. The gold standard investigation is always a CT of the face. When you're evaluating an infant for a cleft lip repair, you're going to rely on the famous rule of tens. This is incredibly common in vivas and multiple choice questions. The criteria are simple. The infant needs to be at least 10 weeks of age, weigh at least 10 pounds, and have a hemoglobin level of at least 10 grams per deciliter.
Mapping this onto a developmental timeline makes perfect sense of the surgical scheduling. At 10 weeks, the rule of tens is met. Then, around 3 months, the cleft lip repair is safely performed. But notice how the cleft palate repair is delayed until 9 to 12 months of age. The examiner is going to want to know why we wait, but not wait too long. It's perfectly timed to repair the palate right before normal speech development begins so we can prevent any speech pathology down the line.
Finally, Section 5, Debatables and High-Yield Facts. Think of this as your safety net. We're going to catch those confusing nuances and finish strong. So, take a look at this specific question. What is the most common facial fracture? It seems simple, right? But the correct answer actually shifts depending on exactly how the examiner words the question. Let's clarify.
What's truly interesting here is how we have to navigate the gray areas in medicine. For the most common facial fracture, the nasal bone is correct overall. But if the question specifically asks about major facial fractures requiring surgery, the answer might actually differ. Similarly, for mandibular fractures, the condylar process is the standard correct answer. But just be aware that some adult trauma series report the angle as the most common. You have to follow the context clues in the vignette. And for Ludwig's angina, there is no debate. Airway protection always precedes antibiotics and drainage.
All right, let's lock in these final high-yield one-liners. Remember that Little's area is the most common site of epistaxis, while posterior bleeds usually arise from the sphenopalatine artery. For tumors, pleomorphic adenoma is your most common salivary gland tumor overall, but if they ask for the most common malignant one, it's mucoepidermoid carcinoma. And never forget, the facial nerve is always the nerve at risk during a parotidectomy.
Moving on to malignancies, squamous cell carcinoma, or SCC, is the commonest oral and laryngeal cancer, with the lateral border of the tongue being the most frequent oral site. Keep in mind that erythroplakia carries a much higher risk of malignant transformation than leukoplakia. For facial trauma, the nasal bone is your commonest facial fracture. If you see an aspirated foreign body, it's almost certainly in the right main bronchus. And finally, a thyroglossal duct cyst moves with swallowing and tongue protrusion, and it has to be treated with the cystrung procedure.
All right, moving on to bypass conduits. When you're replacing a blocked vessel, the choice of that replacement is highly tested. The absolute crucial point here is long-term patency. The best conduit for bypassing the LAD, the left anterior descending artery, is the left internal mammary artery, or LIMA. Why? Because arterial grafts just have significantly better long-term patency than vein grafts. But when a venous graft is needed, your go-to is the great saphenous vein. Watch out though, they'll try to trick you by listing the small saphenous vein. Always remember, great saphenous is the most common.
This next part brilliantly illustrates a classic trade-off you simply have to memorize. Test questions love to give you a patient profile, maybe a young athlete or an elderly patient with a history of bleeding, and ask you to pick the right valve. A mechanical valve gives you incredible durability. It really won't wear out easily. But that durability comes at a steep price, lifelong anticoagulation. On the flip side, a bioprosthetic valve, which is usually made from animal tissue, completely frees the patient from lifelong blood thinners. That's a massive advantage, right? The trap here is forgetting that bioprosthetics just don't last as long, meaning the patient might need a reoperation down the road.
Let's look a little closer at those blood thinners for mechanical valves. Please, do not let the exam writers trick you here. You might be really tempted to guess DOACs, direct oral anticoagulants, just because they're newer and we hear about them all the time. But mechanical valves absolutely require warfarin, no exceptions. DOACs are just not used for mechanical valves. Also, pay close attention to the valve position. The prosthetic valve with the absolute highest thrombosis risk is the mechanical mitral valve. It poses a way higher clotting risk than a valve in the aortic position.
Section 2. Endocarditis and aortic disease. Let's move into some surgical emergencies and infectious destruction and see how to handle these acute, life-threatening scenarios.
So, for infective endocarditis, the most common indication for surgery is actually heart failure caused by valve destruction. Sure, uncontrolled infection or emboli are valid reasons too, but don't assume a mild infection automatically means you need to call a surgeon. Next, you've got to know your bugs. The most common organism for native valve endocarditis? That's Staphylococcus aureus. And finally, take a really good look at the imaging trap here. Transesophageal echocardiography, or TEE, is the correct choice for detecting vegetations. The trap they'll set is the standard transthoracic echo, or TTE. But remember, the TEE puts the probe right down the esophagus, literally right behind the heart, making it incredibly sensitive compared to a TTE.
Now let's talk aortic dissections. When a question describes someone having sudden, tearing chest pain that radiates straight to their back, you need to immediately split your brain into type A versus type B, using a super simple anatomical rule. Stanford type A involves the ascending aorta. This is a surgical emergency. They need the OR right now. Stanford type B involves the descending aorta only. The trap they love to set is rushing a type B patient to the operating room in your answer choices. But actually, type B is usually managed medically first with aggressive blood pressure control unless there are complications. So remember, ascending means OR, descending means medicine first.
So how exactly do we image these dissections? Well, it entirely depends on the patient's hemodynamics. If your patient with a suspected dissection is stable, CT angiography is your best initial step. That's the correct answer. But if they're unstable, hypotensive, and basically hemodynamically crashing right in front of you, they cannot safely go to the CT scanner. In that exact scenario, TEE is your rapid bedside answer.
Section 3. Congenital heart disease traps. Let's transition over to differentiating confusing pediatric presentations, which I know can feel a bit overwhelming, but we'll break it down logically.
Okay, this is an incredibly high-yield concept right here. Let's break it down. The most common congenital heart disease overall is a ventricular septal defect, or VSD. Easy enough. But what if the child is cyanotic? They have that bluish discoloration from a lack of oxygen? Listen closely. The age of the cyanotic child is the entire key to the question. The most common cyanotic condition at birth, meaning a brand new baby, is transposition of the great arteries. This is a massive exam trap, guys. Students so often just jump straight to tetralogy of Fallot whenever they see the word cyanosis. But tetralogy of Fallot is the most common cyanotic condition after the neonatal period, so think an older infant or toddler. Keep that straight and you will save yourself so many points.
Also, be on the lookout for visual descriptors. Test writers absolutely love using classic X-ray findings as traps. You have got to anchor the term boot-shaped heart to tetralogy of Fallot. It looks like a boot because the right ventricular hypertrophy physically lifts the apex of the heart up. On the flip side, reserve the phrase egg on a string strictly for transposition of the great arteries. That's where the narrow mediastinum actually looks like a string holding up an egg-shaped heart.
Section 4. Pericardial and post-op complications. We're doing great. Let's explore the aftermath of surgery and critical care, specifically looking at pericardial emergencies.
All right, let's dive into this absolute classic definition. If a post-op or trauma patient suddenly crashes on you and the vignette gives you 3 very specific signs, hypotension, raised jugular venous pressure, and muffled heart sounds, you must instantly recognize Beck's triad. This triad points directly, do not pass go, straight to cardiac tamponade. That's when fluid or blood fills up the pericardial sac, literally crushing the heart so it just can't pump.
Another vital sign of tamponade you'll see is pulsus paradoxus, that abnormally large drop in blood pressure when the patient takes a breath in. Now, while pulsus paradoxus strongly points to tamponade, which requires an emergency pericardiocentesis with a needle to drain the fluid, keep in the back of your mind that test writers love to use severe asthma as a tricky alternative cause. Always correlate it with the rest of the clinical picture. But for our cardiac surgery patients, it almost always means tamponade and requires emergency treatment.
So, the really crucial point in these post-op scenarios is the timeline. Look at this visual here. Within the first few hours, the most common cause of early postoperative bleeding is just surgical bleeding. If it's severe, the answer is to go back in and surgically re-explore the chest. Also in those early hours to days, a perioperative myocardial infarction can happen. It's rare, but it carries a very high mortality. However, as we move out into days 2 through 4, we see the most frequent postoperative complication overall, atrial fibrillation. It reliably pops up right in that subacute window, so watch out for it.
Now, a slightly later but frankly devastating complication is an infection of the surgical site itself. If a post-op patient develops a deep sternal wound infection, maybe they present with a fever, sternal instability, and purulent discharge, you should immediately suspect Staphylococcus aureus as the serious culprit here.
Section 5. High-yield final review. You've made it to the final stretch. Let's do a rapid-fire summary to really lock these facts in.
Quick review of our conduits and valves. Remember, the Lima is best for the LAD, while the Great Saphenous is the most common venous graft. For valves, mechanical means longer lasting, but requires lifelong warfarin, while bioprosthetics have a lower thrombosis risk, but they just don't last as long. Oh, and atrial fibrillation, that's your most common post-CABG headache. Take just a second to absorb all that.
For emergencies on the wards, a Stanford Type A dissection means you're going to the operating room, while Type B means initial medical management. And please, never forget that the transesophageal echocardiogram, the TEE, is your absolute gold standard for seeing those tiny endocarditis vegetations.
Finally, make sure you match that cyanosis timing to the congenital defect. Transposition is at birth. Tetralogy is after the neonatal period. And never, ever forget that Beck's triad, hypotension, raised JVP, and muffled heart sounds means tamponade, and that requires an urgent pericardiocentesis.
Lung cancer exam traps. Okay, let's break down the 4 main lung cancers. Adenocarcinoma? That's your most common primary lung cancer overall. But if the scenario gives you a smoker with a central lesion, boom, you're looking at squamous cell carcinoma. And here is a huge classic trap. Squamous cell secretes PTHrP, which causes hypercalcemia. Do not fall for SIADH here. SIDH, and ACTH for that matter, belong purely to small cell lung carcinoma. Oh, and for Pancoast tumors? Look for a lesion at the apex of the lung, not the lower lobe. And remember, it's associated with Horner syndrome. Don't get tricked by a distractor that only mentions ptosis without the full syndrome. Now, looking at management, the contrast is really stark. For early-stage non-small cell lung cancer, your definitive treatment is surgical resection, specifically a lobectomy. The trap is picking a pneumonectomy. It's just way too aggressive and rarely the correct answer. On the flip side, small cell carcinoma is pretty much considered systemic from day 1. Because of that, surgery is almost never indicated. The correct answer there is going to be chemotherapy, maybe with some radiotherapy, but definitely not the scalpel. So how do we actually work up a lung nodule chronologically? Getting this flow right will save you so many points. Step 1 is diagnosis. Now listen carefully. Imaging alone is never diagnostic. You absolutely need a histopathological biopsy. Thinking a scan is enough is a major trap. Step 2 is staging, which is best done with a PET-CT. And just a heads up, a brain MRI is only for highly selected patients, not everyone. Finally, step 3 involves checking those mediastinal nodes. You'll typically start with an EBUS-guided biopsy, keeping a mediastinoscopy as a backup option if you really need it. Section 2, pleural and space emergencies. All right, I cannot stress this rule enough. If you have a patient presenting with sudden dyspnea, hypotension, and a tracheal shift, you are dealing with a tension pneumothorax. And here is the absolute most lethal trap you will see on the exam, choosing to wait for a chest x-ray. No, this is 100% a clinical diagnosis. Waiting for imaging in this scenario will literally cost the patient their life, both in the real world and on your test. So, what is the exact sequence of survival here? Step 1, obviously, is recognizing those vital signs, the sudden dyspnea and hypotension. Step 2, and this has to happen immediately, is needle decompression. You must relieve that pressure instantly. Then, and only then, do you move to step 3, which is placing the definitive chest tube. If you pick chest tube before decompression, you'll get the question wrong, guaranteed. Speaking of chest tubes, precise anatomy is everything. You want to aim for the safe triangle. That's the 4th to 5th intercostal space, right in the anterior to mid-axillary line. But here's the classic Viva and written exam trap. The intercostal vessels run right along the inferior border of the rib. So, to avoid hitting that neurovascular bundle, you must always insert the tube just above the upper border of the rib. Moving on to pleural diseases, let's clear a few things up. An empyema is most commonly caused by a parapneumonic infection, not tuberculosis. If you're looking at a suspected effusion, you'll start with a chest x-ray, sure, but the actual diagnostic requirement is a thoracentesis for fluid analysis. We use Light's criteria to figure out if it's an exudate. Oh, and a quick note on malignant effusions. Lung carcinoma is actually the #1 cause. Examiners love to bait you with breast cancer, but that comes in second. Okay, 1,500. This is your magic number for a massive hemothorax. Initial management is a chest tube, but if you immediately drain more than 1,500 milliliters of blood, or if they continue bleeding at over 200 milliliters an hour for 3 hours, that indicates you need a thoracotomy. Just lock that number in your brain right now, 1,500. Section 3, esophagus and mediastinum facts. Here's a really sneaky epidemiological trap. If a question asks for the most common cause of an esophageal perforation, a lot of students instantly jump to Borhave syndrome, just because we study it so much. But the correct answer, it's iatrogenic. Yep, medical procedures like endoscopies are actually the most common culprit. So always read the question carefully to see if they're asking for the most common cause overall. Now, even though iatrogenic is the most common overall, Borhave syndrome is still incredibly high yield.
The classic presentation is severe chest pain right after forceful vomiting, which points to a full-thickness rupture. But the trap here is in the management protocol. You absolutely have to investigate with a water-soluble contrast swallow. Never ever choose barium initially. If barium leaks through that rupture, it triggers a catastrophic, lethal mediastinitis.
For anterior mediastinal masses, you simply need to remember the 4 T's: thymoma, teratoma, thyroid, and terrible lymphoma. But the absolute star of the show here, and the most common anterior mediastinal tumor in adults, is the thymoma. If they describe a patient with muscle weakness that gets worse as the day goes on, meaning myasthenia gravis, and they have an anterior chest mass, you are looking at a thymoma.
Section 4. High-yield chest trauma.
Let's start by getting the exact definition of a flail chest down. It is defined as having 3 or more consecutive ribs fractured in 2 or more places. This creates an unstable segment that causes paradoxical chest wall movement. That means the flail segment actually pulls in when they breathe in and pushes out when they breathe out. So memorize those numbers: 3 or more ribs in 2 or more places. And that brings us to a huge distractor. What actually kills the patient or causes the severe hypoxia in a flail chest? The trap is thinking that it's the broken ribs themselves or that weird paradoxical movement. The correct answer is the underlying pulmonary contusion. It's the bruised lung tissue underneath those fractures that prevents proper gas exchange, and that is the true danger. Actually, pulmonary contusion is the single most common serious injury following blunt chest trauma overall. Another trauma essential you really have to know is traumatic aortic injury. This is caused by rapid deceleration. Think high-speed car crashes. The shear force tears the aorta at its most tethered point. For the exam, know that this is the aortic isthmus, right near the ligamentum arteriosum, which is where the mobile arch meets the fixed descending aorta.
Section 5. Rapid-fire exam review. All right, let's lock all this in. Adenocarcinoma, most common overall. Squam cell, think smokers and hypercalcemia. Small cell pairs with SIADH and ACTH, and you treat it with chemoradiotherapy, never surgery. A Pancoast tumor guarantees Horner syndrome, and detention pneumothorax is purely a clinical diagnosis. You decompress instantly, absolutely no waiting for x-rays.
Continuing on, always insert chest tubes just above the upper border of the rib to protect the vessels. If a hemothorax drains over 1,500 milliliters, you are moving straight to a thoracotomy. Remember that empyema almost always follows a simple pneumonia. For Borjev syndrome, water-soluble contrast is your only safe choice. And finally, traumatic aortic ruptures tear at the aortic isthmus. There you go. You now have every major trap safely mapped out.
So let's talk about acute limb ischemia. You probably know the most common cause is a cardiac embolism, specifically from AFib, right? With thrombosis coming in second. But here is the classic exam trap you are going to see time and time again. Examiners love to try and trick you into waiting for a CT angio when the limb is actively threatened. Don't fall for it. You literally cannot delay. You have to start immediate IV heparin before definitively treating with an embolectomy or revascularization. Now, CT angio is the gold standard investigation, for sure, but only, and I mean only, in a stable patient where it absolutely won't delay limb-saving treatment. Oh, and if you see paralysis on the exam, beware. It means irreversible muscle infarction. To spot this clinically, just remember the 6 Ps: pain, pallor, pulselessness, paresthesia, paralysis, and poikilothermia, which just means a cold limb. Lock these in your brain. But honestly, as I just mentioned, paralysis is the absolute most ominous sign here. Why? Because it indicates irreversible muscle infarction. If you see paralysis in a clinical vignette, that tissue is already dying. There's no going back. Now, when you're dealing with vascular trauma, the whole thing boils down to a clearer triage pathway. You've got to distinguish between hard signs and soft signs. Hard signs are things like active bleeding, an expanding hematoma, an absent pulse, a bruit or thrill, or distal ischemia. If you see these, immediate trip to the operating room, no questions asked. Conversely, soft signs like a history of bleeding, maybe a small, stable hematoma, a neurologic deficit, or a proximity injury, these buy you a little time. They afford you the luxury of ordering a CTA to properly assess the damage.
Okay, moving to blunt vascular trauma. A classic Viva question trap is pinpointing the exact location of an aortic injury. Remember, it's most commonly the aortic isthmus, right near the ligamentum arteriosum. Now, while a CTA is your best bet for a stable trauma patient, if you're actually in the OR doing damage control surgery, a vascular shunt is going to be your best temporary friend before you can safely perform a definitive repair. Let's transition over to Section 2, aneurysms and arterial disease.
we're shifting gears to chronic, insidious pathologies now.
So, breaking down aneurysms. The absolute most common arterial aneurysm is, of course, the abdominal aortic aneurysm, or AAA. And the crucial pearl here is that they are infrarenal in the vast majority of cases. Now, don't get tripped up by the cause. A lot of people think it's just due to hypertension. While hypertension is definitely a risk factor, atherosclerosis is the primary driver here. Also, keep in mind that the most common peripheral arterial aneurysm is the popliteal artery aneurysm. Examiners absolutely love to test the fact that these are notoriously bilateral.
Managing a AAA is quite literally all about timing. You're looking at elective repair when the diameter hits 5.5 centimeters or greater in men, or earlier if it's rapidly expanding or symptomatic. But watch out for this major pitfall. Do not wait for a pulsatile abdominal mass to diagnose a ruptured AAA. We're taught the classic triad, right? Sudden abdominal or back pain, hypotension, and a pulsatile LAS. But in reality, that triad is not always complete. Sudden pain with hypotension is more than enough to sound the alarm for a rupture.
Let's talk peripheral arterial disease, or PAD. Your first-line screening is always the ankle brachial index, or ABI, with a normal result sitting between 1.0 and 1.4. For imaging, digital subtraction angiography, DSA, is technically the gold standard, though you'll see CTA commonly used before interventions. Clinically speaking, you really need to grasp the difference in symptoms here. Intermittent claudication is your most common symptom, sure, but if a patient tells you they have pain at rest, that's a massive red flag. Rest pain signals critical limb ischemia, which demands much more urgent management. To put that ABI screening into a testable perspective, an ABI of less than 0.9 is your definitive threshold for confirming PAD in your patients. It's that simple. Just lock that number in your head. Less than 0.9 equals PAD.
Next up, carotid disease. If you have a patient presenting with symptomatic carotid stenosis of over 70%, your definitive treatment is a carotid endarterectomy, assuming they're a good surgical candidate, of course. But what's your very first move? Carotid duplex ultrasound. That is your best initial investigation, which then paves the way for confirmation with a CTA or MRA down the line.
Moving right along to Section 3, venous disease and DVT. Let's explore the low-pressure, high-capacitance system. Okay, a super common Viva question asks you for the staging system of chronic venous disease. It's the CEAP classification. CEAP. For varicose veins, you absolutely must know that great saphenous vein incompetence, which you might hear older surgeons call the long saphenous vein, is the main culprit. And just like with carotid disease, your gold standard investigation here is the duplex Doppler ultrasound. The trap to avoid? Choosing venography. It's invasive, it's outdated for this, and it is definitely not your first-line choice today.
You're going to see this next concept on literally every exam. Virchow's triad. It dictates the 3 massive risk factors for thrombosis that you have to assess in every single surgical patient. 1. Stasis of blood flow. 2. Endothelial injury. And 3. Hypercoagulability. If your patient has even one of these, the risk for a DVT absolutely skyrockets. So when you suspect a DVT, what do? The best initial investigation is the compression duplex ultrasound. Do not fall for the D-dimer trap. D-dimer only helps you rule out DVT in low-risk patients. It does not confirm it. Clinically, a massive pulmonary embolism is obviously the most immediate, life-threatening danger here. But examiners also want to see that you understand the long-term picture. Post-thrombotic syndrome is the most common long-term complication, and that leads to chronic edema and those really debilitating venous ulcers. All right, Section 4. Dialysis Access Essentials. Let's quickly review the operations required for our end-stage renal disease patients. The radiocephalic AV fistula at the wrist, also known as the Breccia-Cimino fistula, is absolutely your preferred first choice for permanent dialysis access. It uses native vessels, so it has fantastic longevity. But you've always got to be on the lookout for its most common complication, which is thrombosis. You might be tempted to think of infection first, but infections are actually much less common in native fistulas compared to prosthetic grafts. That's a super frequent multiple choice trap, so keep it in mind. And finally, Section 5, high-yield exam pearls. Let's do a rapid-fire review to scientifically reinforce everything right before test day. Okay, let's lock these facts in. The 6 Ps, that equals acute limb ischemia. Your very first move for ALI, immediate IV heparin. Paralysis, that means irreversible muscle ischemia. And ABI under 0.9, diagnostic for PAD. Duplex ultrasound,
That's your absolute go-to imaging for almost all venous disease, including varicose veins and DVTs. And great saphenous vein incompetence, that's the primary cause of most varicose veins. Continuing our rapid fire, a pulmonary embolism is the most dangerous complication of a DVT, but post-thrombotic syndrome is the most common long-term complication. Remember, AAAs are primarily infrarenal and driven by atherosclerosis, and you're going to repair them electively at 5.5 centimeters in men. Next, any hard sign of vascular injury means you skip the CTA scanner and go straight to the OR, period. And finally, the radiocephalic AV fistula remains your top choice for dialysis access.
Navigating common traps. Let's dive right into our first minefield, brain tumors and the life-threatening herniation syndromes they can trigger.
Examiners absolutely love using wordplay to trip you up here. For instance, if a scenario asks for the most common primary malignant brain tumor in adults, your answer is glioblastoma multiforme, or GBM. The trap, they'll heavily hint at a meningioma. But remember, while meningioma is the most common primary brain tumor overall, it's typically benign. Don't let them trick you with that. In children, if they just ask for the most common tumor, it's the benign pilocytic astrocytoma. But the second they add the word malignant, your mind needs to immediately jump to medulloblastoma, which you'll find in the posterior fossa.
Moving on to specific presentations, location and classic imagery are super highly tested. For the most common brain metastases overall, lung carcinoma takes the top spot. The trap they'll use here is melanoma. They might describe an actively bleeding tumor because melanoma metastases bleed the most frequently, but mathematically, lung is still the most common. Next, if you get a classic image of a tumor crossing the corpus callosum, you're looking at a glioblastoma, specifically a butterfly glioma. And finally, for a tumor at the cerebellopontine angle causing hearing loss, trust that it's a vestibular schwannoma, not a meningioma.
What's really crucial here is how age completely changes the diagnosis for tumors in the posterior fossa. If your clinical vignette describes a child with a posterior fossa mass, specifically located in the midline cerebellar vermis, you're dealing with a medulloblastoma. However, if that exact same anatomical location is described in an adult patient, the most common answer shifts entirely to a hemangioblastoma. Always highlight the patient's age in the question stem first.
Of course, tumors take up space, and that brings us to herniation syndromes. You really need to carefully differentiate the neurological deficits here. In an uncal herniation, the medial temporal lobe squeezes down, and the very first thing it hits is cranial nerve 3. This classically presents as a dilated fixed pupil on the same side. On the flip side, a tonsillar herniation involves the cerebellar tonsils pushing down through the foramen magnum. This directly compresses the medulla, which controls breathing. So the outcome there is fatal respiratory arrest. Pupil issue, uncal. Breathing issue, tonsillar.
Section 2. Trauma and hemorrhage. Bleeds and hematomas. Let's see how these spatial concepts build into some easily confused trauma scenarios.
When you see head trauma on an exam, it's tempting to rush, but let's slowly break down this classic comparison. An epidural hematoma is an arterial bleed, typically the middle meningeal artery. The patient gets hit, wakes up feeling totally fine during their lucid interval, and then rapidly deteriorates. On a CT, it forms a tight, lens-shaped or biconvex bleed because it's constrained by the skull's suture lines. Conversely, a subdural hematoma is a slower venous bleed from torn bridging veins. It's most common in the elderly or alcoholics due to brain atrophy. Because it's below the dura, sutures don't stop it, so it forms a long, crescent-shaped bleed wrapping around the brain.
Now, how do we investigate these? Always remember that a non-contrast CT of the brain is your absolute best initial step. The trap is offering you an MRI. Don't take the bait. MRI just takes way too long in an emergency. If your patient has a normal initial CT but suffers delayed neurological deterioration, the trap is to just observe them. The correct answer is to suspect an expanding hematoma and immediately repeat that CT scan. Finally, the most important predictor of traumatic brain injury outcome is the patient's post-resuscitation Glasgow Coma Scale, not their initial GCS at the scene.
This protocol for a ruptured berry aneurysm causing a subarachnoid hemorrhage is highly tested. It always starts with that sudden, severe thunderclap headache. Your immediate reflex? Non-contrast CT. But here's a massive trap. If your clinical suspicion is high but the CT is negative, you must perform a lumbar puncture to look for blood or xanthochromia. To find the actual aneurysm, the gold standard is digital subtraction angiography, or DSA, not just a standard CT angiography. And to prevent the major delayed complication of cerebral vasospasm, you must always administer nimodipine.
Section 3.
raised ICP and hydrocephalus, pressures and fluids. Next, we'll tackle the pressures inside the skull and navigate those tricky rules.
Let's establish our baselines. Normal ICP is between 5 and 15 millimeters of mercury. Anything over 20 is abnormal and demands action. Now pay close attention here. You cannot confuse the simple triad of raised ICP, which is just headache, vomiting, and papilledema, with the Cushing triad. The Cushing triad is hypertension, bradycardia, and irregular respirations. That is a massive red flag. It's the brain's desperate attempt to maintain perfusion, and it tells you herniation is impending. Immediate treatment involves head elevation and osmotic agents. But remember, definitive treatment always targets the underlying cause.
Speaking of osmotic agents, here's a really sneaky pharmacology trap. If your patient has raised ICP, you naturally want to draw fluid out of the brain, usually with mannitol. But what if your patient is a trauma victim who is also hypotensive from blood loss? The exam trap desperately wants you to pick mannitol by reflex. You must not do this. Mannitol is a diuretic. It'll make them pee out volume and severely worsen their hypotension. In a hypotensive patient, you have to choose hypertonic saline to reduce brain swelling while simultaneously supporting their blood pressure.
For hydrocephalus, context is everything. The most common cause of obstructive hydrocephalus, especially in pediatric questions, is aqueductal stenosis. For a communicating hydrocephalus, the gold standard treatment is a ventriculoperitoneal or VP shunt. The exam might try to distract you with endoscopic third ventriculostomy or ETV, but that's generally reserved for obstructive cases. And notice this key fact. While a VP shunt is life-saving, the most common complication to watch out for is actually mechanical obstruction of the tubing. Infection is only the second most common.
Section 4. Spine and NTDs, back and neural tube. Let's move gracefully down the central nervous system and explore some high-yield spine pathology.
The anatomy of a lumbar disc prolapse creates the absolute perfect exam trap when it comes to nerve root numbering. The most common level for herniation is L4, L5. But because of how the nerve roots exit, a posterolateral disc herniation at L4, L5 actually misses the L4 root and compresses the traversing L5 nerve root. Similarly, an L5-S1 prolapse compresses the S1 nerve root. Do not let the upper number fool you. And to visualize this soft tissue beautifully, your best investigation is always an MRI of the spine.
Cauda equina syndrome is one of the few true, absolute surgical emergencies in spine care, and it is highly time-critical. The timeline here is everything. The trap is thinking back pain is the key indicator, but almost everyone has back pain. The actual earliest specific symptom you need to hunt for in the vignette is urinary retention. That eventually progresses to the classic sign of saddle anesthesia, numbness anywhere that would touch a saddle. If you see this, they're steering you toward the only correct answer. Emergency surgical decompression within 24 to 48 hours to save their bowel and bladder function.
Let's gently contrast our pediatric neural tube defects. Spina bifida occulta is the most common neural tube defect overall, but the word occulta literally means hidden. It's usually entirely asymptomatic, maybe just presenting as a small dimple or a tuft of hair on the lower back. Contrast that with myelomeningeal, which is a severe protrusion of both the meninges and the spinal cord. The exam loves testing associations here. A myelomeningeal is heavily linked to Arnold-Chiari II malformations and concurrent hydrocephalus.
Section 5. High-Yield One-Liners Rapid-Fire Review. We've navigated the complex minefield of these topics beautifully so far. Now, let's lock in that confidence with a rapid-fire review. When you see these cues, your brain should automatically snap to the correct answer.
If you calculate the Glasgow Coma Scale and it's 8 or less, there's no debate, no waiting. The golden rule is less than 8 in debate. You must secure that airway immediately.
This quote is a foundational rule, both on the neurosurgery wards and on your exams. A patient with a head injury who develops a cranial nerve 3 palsy and a blown dilated pupil, that's an uncal herniation until proven otherwise.
When reading a CT scan description, you honestly don't even need to see the image. The moment you see biconvex or lens-shaped, link it to an arterial epidural hematoma. And if you see crescent-shaped, it's a venous subdural hematoma.
And finally, if they describe a patient with urinary retention and saddle anesthesia, do not choose observation and definitely do not choose steroids alone. A cauda equina presentation is an absolute surgical emergency requiring immediate decompression.
Disc herniations and emergencies. Now, the rule for nerve root compression is actually remarkably simple, despite how incredibly confusing the questions can get. When you have a posterolateral disc herniation in the lumbar spine, it typically spares the exiting nerve root and compresses the traversing nerve root. In other words, it hits the lower one. So, an L4-L5 disc prolapse correctly compresses the L5 nerve root. The big exam trap here? They'll try to trick you into choosing the upper root, or they'll make you second-guess which one is actually the lower root. Similarly, an L5-S1 prolapse compresses the S1 root. Up in the cervical spine, the most common prolapse is at C5-C6, and this compresses the C6 nerve root. If you memorize this rule, you will literally never miss these points. But knowing the nerve root is really only half the battle, right? You also have to know how to test for it clinically. The straight leg rays test L4 to S1 nerve root irritation, and it is highly sensitive. It's almost always positive in a disc prolapse. However, the exam trap is when they ask for the most specific test. That would be the crossed straight leg raise. If raising the unaffected leg causes pain in the affected leg, it is highly specific for a disc herniation, even though it's less sensitive overall. So to put that simply, sensitivity goes to the straight leg raise, but specificity goes to the crossed straight leg raise. Let's shift gears to a true surgical emergency, cauda equina syndrome. This is most commonly caused by a massive central lumbar disc prolapse. Now pay very close attention to this timeline because it's crucial. The earliest bladder symptom is urinary retention. The trap? Examiners love to list urinary incontinence as an option just to tempt you. While incontinence does happen later due to overflow, retention is the earliest sign. The classical triad you absolutely cannot miss is saddle anesthesia, urinary retention, and bilateral leg weakness. When you see this triad, the definitive treatment is emergency surgical decompression within 24 to 48 hours. Delaying this even a little bit worsens the neurological outcome permanently.
When it comes to investigating these issues, MRI is absolute king. For a disc prolapse, the best investigation is an MRI of the spine. You should only ever choose CT if the prompt specifically states that an MRI is contraindicated or totally unavailable. The absolute gold standard for spinal cord compression? An MRI with contrast. Do not fall for the CT scan trap there. Furthermore, if an older adult presents with spinal issues, you've got to consider cervical myelopathy, which is most commonly caused by cervical spondylosis. The trap here actually lies in the physical exam signs. Because the cord itself is compressed, cervical myelopathy causes upper motor neuron signs in the legs. We're talking hyperreflexia, a positive Babinski sign, and clonus. This is a stark contrast to lumbar radiculopathy, which presents with lower motor neuron signs.
Moving right along to Section 2, Spinal Cord Syndromes and Injury Patterns.
For incomplete syndromes, central cord syndrome is by far the most common. It happens via hyperextension injuries, and the trap here is remembering that motor loss is greater in the upper limbs than the lower limbs. Basically, the arms are weaker than the legs. Next, Brown-Séquard syndrome results from a spinal hemisection. With this one, you get ipsilateral loss of motor function and proprioception, but a contralateral loss of pain and temperature. Then we have anterior cord syndrome, often from an anterior spinal artery injury. You lose motor, pain, and temperature, but the exam trap is that vibration and proprioception are unexpectedly preserved simply because the posterior columns are spared. Posterior cord syndrome is quite rare, but it features an isolated loss of vibration and proprioception.
Okay, Section 3, spinal fractures and those high-yield epidens. You really must memorize these distinct associations. A Jefferson fracture is a C1 burst fracture caused by axial loading. Think of a diving injury where the head strikes the bottom of a shallow pool. A hangman's fracture is a fracture of the C2 pars interarticularis, classically caused by extreme hyperextension. Now, a chance fracture is a flexion-distraction injury, and the classic exam trap buzzword for this one is a seat belt injury from a motor vehicle accident. Finally, a burst fracture involves retropulsed bone fragments pushed back into the spinal canal, which makes a neurological injury very, very common. Next up is Section 4, infections and tumors, primary versus secondary. First, let's untangle spinal infections. If a question asks you for the most common spinal infection overall, the answer is pyogenic spondylodiscitis, and that is overwhelmingly caused by Staphylococcus aureus. Please do not choose tuberculosis unless the patient has specific risk factors or is from an endemic region. When it is tuberculosis of the spine, it's known as Pott's disease. And the highly tested exam trap here is the location. Pott's disease most commonly involves the thoracic vertebrae.
Let's look at how this builds your diagnostic workflow. Step 1 is always getting an MRI. It's the best investigation to detect the absolute earliest changes of a spinal infection. But hold on, here is the trap. An MRI alone is not definitive. Step 2 is an absolute requirement for a definitive diagnosis, and that is a biopsy with culture. Relying on imaging alone to identify the organism is a classic exam trap that students fall for every single year. You always have to get the tissue.
That exact same cautious logic applies to spinal tumors. examiners are totally going to try to bait you into choosing a primary tumor. However, the most common spinal tumor overall is statistically always a metastasis. Common primary sources are breast, lung, prostate, kidney, and thyroid. Now, if the question explicitly asks for the most common primary malignant spinal tumor, then and only then is the correct answer multiple myeloma. You have to read the question carefully. Are they asking for overall or primary malignant? And finally, Section 5, scoliosis and fractures, looking at deformity and bone density. For scoliosis, the high-yield facts are pretty straightforward, but they are absolutely essential. The most common type is idiopathic adolescent scoliosis, and it disproportionately affects young girls. The clinical trop here is knowing the initial step in evaluation. The best screening test is the ADAM forward bend test, which detects a paraspinal prominence, otherwise known as a rib hump. Once that's identified, you need imaging to measure the severity, and the standard measurement used on X-rays is called the Cobb angle.
Regarding osteoporosis, the most common osteoporotic spinal fracture is a vertebral compression fracture, classically located at the thoracolumbar junction. Now, you might see a surgical option called a balloon kyphoplasty listed in the multiple choice answers. The exam trap here is treating an asymptomatic fracture. Keep in mind, kyphoplasty is strictly indicated only for painful osteoporotic compression fractures, and even then only in selected patients who just haven't responded to conservative management. Okay, let's bring it all home and rapidly synthesize these absolute must-know one-liners to really solidify this entire study session. Remember this: an L4-L5 disc hits the L5 nerve root. MRI is your absolute investigation of choice for prolapse, compression, infections, and tumors. Cauda equina is a surgical emergency requiring immediate decompression. For cord syndromes, central cord means upper limbs are weaker than lower limbs. Brown-Séquard is ipsilateral motor and contralateral pain and temp loss. Anterior cord preserves vibration and proprioception. And finally, metastases are the most common spinal tumors overall. So, let's map out general fractures. Now, the clavicle is the most common fracture overall, but here's the trap. You have to know exactly where it breaks. It's almost always the middle third. The clavicle is also the most common bone fractured in children, where you really need to be on high alert for green stick fractures. Now, if you see a tibia fracture, think about its anatomy for a second. It's the most commonly fractured long bone simply because it's incredibly vulnerable. It sits subcutaneously, right just under the skin. Moving down to the foot, the calcaneus is the most common tarsal bone fractured, and that's usually triggered by a fall from a height. Oh, and for the shoulder, if a clinical scenario describes an elderly patient coming in after a fall, your mind should immediately jump to a proximal humerus fracture. Okay, let's clear up what is arguably one of the most classic test day confusions out there. In the wrist, the scaphoid is the most commonly fractured carpal bone. The lunate, on the other hand, is the most commonly dislocated carpal bone. Test writers absolutely love to swap these in the answer choices to see if you're paying attention. So just lock this rule into your mind right now. Scaphoid equals fracture. Lunate equals dislocation. Don't let them trick you on this one. Moving down the arm to shoulder and elbow trauma, over 95% of shoulder dislocations are anterior. But what's the exam trap? Well, they'll usually ask for the specific nerve injured or the clinical sign, which is the axillary nerve, and that leads to deltoid weakness. If the dislocation is recurrent, you're looking for a Bankart lesion, which involves the glenoid labrum, or maybe a Hill-Sachs lesion. That's a posterolateral compression fracture of the humeral head. Now, let's compare that to the elbow. While shoulders dislocate anteriorly, elbows usually dislocate posteriorly, especially in adults. Finally, we have to talk about the supracondylar fracture. This is a massive, high-yield topic. It threatens the anterior interosseous nerve, which is a branch of the median nerve, and the brachial artery. And if it happens to heal poorly, the classic, dreaded complication trap they want you to identify is cubitus varus, famously known as the gunstock deformity. All right, let's finish up the upper extremity. If a prompt mentions anatomical snuffbox tenderness, the correct answer is a scaphoid fracture. But here is the hidden danger, the trap. The initial X-ray might actually look perfectly normal. You absolutely must treat it based on your clinical suspicion. Why? Because the scaphoid's blood supply enters at the distal pole, which puts the proximal pole at extreme risk for avascular necrosis, or AVN. Now let's look at the fingers. A simple finger dislocation from, say, a sports injury typically hits the PIP joint. But when tendons rupture, we get a really classic contrast. Jersey finger is a rupture of the flexor digitorum profundus tendon, meaning the patient literally cannot flex the distal joint. Mallet finger, though, is an extensor tendon injury, so the patient cannot extend the distal joint. It's flexion loss versus extension loss. Keep those perfectly separated in your mind.
Section 2, we're moving smoothly down to the lower extremities and the spine. Just a heads up, the traps here heavily revolve around compromised blood supply and very specific nerve damage. When you're dealing with femur and hip trauma, the stakes are super high. A fracture of the femur neck actually has 2 major complications you need to memorize. The most feared complication is avascular necrosis, completely due to disrupted blood supply. But the most common complication is non-union, because these are intracapsular fractures. And that vital blood supply in an adult, it comes from the medial circumflex femoral artery. Now think about a posterior hip dislocation. This is your classic car crash dashboard injury. The major trap here is the sciatic nerve. You must absolutely check its function before and after reducing the dislocation. Lastly, for elderly hip fractures, deciding between arthroplasty or fixation, it entirely depends on whether the fracture is intracapsular or extracapsular. Okay, let's decode one of the most persistent sources of confusion, lumbar disc herniations. An L4-L5 disc herniation compresses the L5 root. An L5-S1 disc herniation compresses the S1 root. So the simple rule of thumb here is that in the lower back, the herniation typically hits the lower numbered nerve root as it exits. And please remember, the exam trap for imaging is trying to get you to choose an X-ray. Don't do it. For these soft tissue disc issues, the best investigation is always an MRI.
All right, moving on to Section 3, tumors and bone infections. Test writers absolutely love testing specific patient demographics and radiographic buzzwords here. So let's break them down nice and clearly. Let's categorize bone tumors precisely how they're going to be tested. The most common benign bone tumor is an osteochondroma, which is also known as an exostosis. But if the question asks for the most common benign tumor excluding exostosis, the answer shifts entirely to osteoid osteoma. And the absolute giveaway trap for osteoid osteoma, it's a patient complaining of night pain that is magically relieved by taking NSAIDs. For malignancies, you really have to pay close attention to the wording. The most common primary malignant bone tumor is an osteosarcoma, and that's typically found around the knee. But what about the most common malignant bone tumor overall in adults? Well, that's metastasis, usually spreading from the breast, lung, or prostate. When it comes to these tumors, visualizing the X-ray buzzwords is basically half the battle. Ewing sarcoma is located in the diaphysis, that's the shaft of the bone, and its classic radiographic trap is this onion skin appearance. In contrast, osteosarcoma sits near the joint, typically around the knee, and it presents with a sunburst appearance or a Codman triangle. If you can just link these specific buzzwords together in your head, onion skin with Ewing, sunburst with osteosarcoma, you are not going to be fooled. Now, for bone infections like osteomyelitis, the most common organism across all age groups is consistently Staphylococcus aureus. But when it comes to diagnostics, you have to be really careful. The best investigation to show the earliest changes is an MRI. However, the definitive diagnosis, the true gold standard, is always a bone biopsy and culture. The trap here is that they'll try to trick you into choosing blood work like ESR or CRP as definitive. They are definitely helpful for sure, but they're not definitive. Only the biopsy is.
Shifting our focus to Section 4, we're going to look at chronic joint conditions and pediatric orthopedics. And for pediatrics especially, patient age is absolutely your ultimate clue.
Let's talk arthritis. In osteoarthritis, or OA, the most commonly affected joint is the knee, with the hip coming in second. When you look at an X-ray for OA, the earliest radiographic change is joint space narrowing. The trap is picking osteophytes. Those bone spurs actually happen much later. For rheumatoid arthritis, or RA, there's a critical safety trap you really must know. The first cervical joint affected is the atlantoaxial joint, or C1-C2. Because of this, you must rigorously screen an RA patient's neck before giving them general anesthesia, just to prevent a catastrophic spinal cord injury during intubation.
In pediatric orthopedics, conditions basically map perfectly to age. It's kind of like a timeline. For infants under 6 months suspected of developmental dysplasia of the hip, or DDH, the correct investigation is an ultrasound. The trap is choosing an X-ray, which is completely useless before the bones actually ossify. For infants and toddlers with clubfoot, the standard treatment trap is knowing it's managed via the Pincetti method of casting. Moving up to a limping child aged 4 to 8 years, you're looking at Perthes disease, which is AVN of the femoral head. But if that limping patient is an obese adolescent, the diagnosis shifts to slipped capital femoral epiphysis, or SCFE. And the critical clinical trap there, whatever you do, do not force the hip during examination. Okay, Section 5. We're entering our final stretch. We're going to look at the biological process of bone healing. But first, we urgently need to talk about the most critical, limb-threatening emergency in all of orthopedics:
I want you to just pause and think about this for a second. What is the absolute earliest sign of a true orthopedic emergency, specifically compartment syndrome, especially when the trap is that the patient still has perfectly normal pulses?
The earliest sign is pain on passive stretch. The trap test writer set is specifically telling you the pulses are present, basically trying to lull you into this false sense of security so you rule out compartment syndrome. Do not fall for it. Pulses are maintained until very, very late in the process. The definitive treatment is an emergency fasciotomy. If you wait for the pulse to disappear, you've waited way too long, and unfortunately, the muscle is likely already dead.
Let's cool down a bit with the biology of fracture healing. In the early cellular phase, macrophages are super important initially to clean up. But the exam trap is asking for the most important cell overall, which is the osteoblast, the builder. Next, you need to differentiate secondary and primary bone healing. Secondary healing happens with relative stability, and its absolute hallmark is callus formation. Primary healing, however, requires rigid fixation, like plates and screws, and it bypasses the callus stage entirely, meaning there's little to no callus formed at all. All right, we're going to consolidate all this with some rapid-fire, super high-yield one-liners just to really empower you before exam day. The clavicle is the commonest fractured bone overall. In the wrist, remember, the scaphoid is fractured, the lunate is dislocated. Up top, an anterior shoulder dislocation injures the axillary nerve. Down below, a posterior hip dislocation injures the sciatic nerve. A femur neck fracture leads to that feared complication of AVN. And for tumors, osteosarcoma means knee location, sunburst appearance, and a Codman triangle.
Continuing that momentum right into part 2, Ewing sarcoma sits in the diaphysis and looks like an onion skin. Staphylococcus aureus is your commonest cause of osteomyelitis across the board. Pain on passive stretch is the early sign of compartment syndrome, even with normal pulses. In the spine, an L4-L5 disc compresses the L5 root, while an L5-S1 disc hits the S1 root. For the limping child, Perthes is ages 4 to 8, while SCFE is for obese adolescents. And lastly, for DDH in infants under 6 months, skip the X-ray and go straight to the ultrasound.
Neonatal and upper GI traps. Let's navigate some of these early life threats.
Okay, let's dive into our first region. Differentiating the types and timing of emesis is absolutely crucial. It can literally save a newborn's life and definitely save your test score. Notice how the baby's age and the presence of bile immediately build out our differential diagnosis. If you've got a neonate with bilious vomiting, that is malrotation with midgut volulus until proven otherwise. It's a straight-up surgical emergency. But here's the trap. If a question asks for the most common cause of overall neonatal obstruction, examiners love to throw Hirschsprung's disease in there to distract you. The actual truth is jejuno-ileal atresia. Now, moving along our timeline, if the baby's a bit older, say 2 to 8 weeks, and presents with non-bilious projectile vomiting, well, your mind should immediately jump to hypertrophic pyloric stenosis.
Let's zoom in on pyloric stenosis for a second, because this is a classic trap. The presentation is usually pretty obvious, but the management, that's where they really test your clinical judgment. Examiners will practically beg you to rush straight to the definitive surgery, the Ramsden pyloromyotomy. Do not take the bait. You have to strictly select step 1 first, correct the dehydration and the electrolyte imbalance. Since these babies are constantly vomiting stomach acid, they develop a classic hypochloremic, hypokalemic metabolic alkalosis. You absolutely cannot safely put a baby to sleep for surgery with those metabolic derangements. Resuscitate first, operate second.
I really want you to lock these clinical comparisons into your memory. On exams, spotting these clues quickly is half the battle. For pyloric stenosis, the absolute truth on a physical exam is feeling an olive-shaped mass in the right upper quadrant. If you read that phrase, boom, you've got your diagnosis. Then there's Meckel diverticulum. The core truth here is that it's the most common congenital anomaly of the GI tract. And the giveaway exam clue? The rule of 2s. Think about it. It occurs in 2% of the population, it's 2 feet from the ileocecal valve, 2 inches long, has 2 types of ectopic tissue, gastric and pancreatic, and usually shows up before 2 years of age. These are your solid anchor points for any upper GI questions.
Moving slightly up the track, let's talk about esophageal atresia. If you have a baby who's frothing at the mouth with excessive salivation and you literally can't pass a nasogastric tube, which, by the way, you should confirm with an X-ray seeing it coil in the upper pouch, you're looking at esophageal atresia. The most common type, making up over 85% of cases, is type C. That's esophageal atresia with a distal tracheoesophageal fistula. But wait, here comes the trap. You might correctly identify the atresia, but forget to look at the whole baby. Always check for the VACTERL association. That's vertebral, anorectal, cardiac, tracheoesophageal, renal, and limb anomalies. If you find one, you must actively hunt for the others.
Moving on to Section 2, Lower GI and Anal Rectal Anomalies. Let's decode some distal obstructions.
As we travel further down the digestive tract, we run into the tricky issue of delayed meconium passage. There are two classic pediatric diseases that love to masquerade as each other in these exam scenarios. When you're trying to figure out why a baby hasn't stooled in their first 48 hours, the big trap is mixing up the associated syndromes. Hirschsprung disease is strongly associated with Down syndrome, whereas meconium ileus is almost entirely linked to cystic fibrosis. Please do not cross these wires. Carefully connect Hirschsprung to Down syndrome and meconium ileus to CF.
Examiners also really love to test your grasp on the diagnostic steps for Hirschsprung disease. Again, don't let them mess with your order of operations. Step 1, your initial investigation, is the contrast enema. This gives you a great initial roadmap, highlighting a transition zone between the normal dilated bowel and the narrow agangliomic bowel. But if a question specifically asks for the gold standard or definitive diagnosis, you skip straight to Step 2, the rectal suction biopsy. Proving the absolute absence of ganglion cells under a microscope, that is your gold standard truth.
Let's pivot to anorectal malformations and look at how they show up differently depending on the patient. The pitfall here is generalizing. For boys, the trap is just clicking imperforate anus when the specific, accurate truth is actually a rectourethral fistula. For girls, the most common malformation is a rectovestibular fistula. But here's the beautiful part. Despite the different presentations, the definitive surgical fix for both is exactly the same: the posterior sagittal anorectoplasty, or as we usually call it, the PSARP or Pena procedure.
All right, Section 3, the acute pediatric abdomen. Time to identify childhood emergencies.
Let's fast forward a little to an older infant or school-aged child who shows up in the ED crying and in severe pain. These next two conditions really highlight some dangerous illusions in acute pediatric care. For intussusception, which typically peaks between 6 and 18 months, the trap is waiting around for the classic triad: colicky pain, vomiting, and red currant jelly stool. The reality? That triad is almost never complete early on. Red currant jelly stool is actually a very late sign of ischemia. Do not wait for it. Then we have appendicitis, the absolute most common surgical emergency in school-aged children. The trap here is assuming these younger kids follow an adult timeline. They really don't. Their omentum is underdeveloped, meaning early appendicitis in young kids is super prone to rapid perforation.
Let's stick with the intussusception workup for a second. Your most crucial, non-invasive tool here is the ultrasound. You're hunting for that classic target sign or donut sign. Please do not fall into the trap of ordering unnecessary CT radiation for a child. Also, the great thing about our next step is that an air or contrast enema is both diagnostic and therapeutic. It literally uses pressure to push the telescoped bowel right back into place. Just be super careful, because the major contraindication here is peritonitis or perforation. If the child is unstable, you bypass the enema and go straight to the OR.
Section 4, Abdominal Wall and Hernias. Let's break down anatomical defects and descents.
Next up, structural defects of the abdominal wall. This is a massive favorite for visual and descriptive comparison questions, so it's a juxtaposition you really need to know. With an omphalocele, you'll see a membranous sac covering the midline defect, but the trap is assuming that protective sac makes it safer. In reality, omphalocele comes with a much higher rate of really dangerous associated congenital anomalies, like chromosomal defects. Now, gastroschisis usually looks way more terrifying in the delivery room because there's no sac at all. The bowels are just out there exposed to amniotic fluid. However, it is typically beautifully isolated just to the right of the umbilicus, completely free of other systemic syndromes.
Pediatric hernias actually operate on completely different mechanisms than adult hernias. In kids, these are overwhelmingly indirect inguinal hernias. And it's not because of muscle weakness, it's actually a congenital issue caused by a patent processus vaginalis that just failed to close. And you know which side is most commonly affected? The right side. Why? Simply because the right testicle descends later than the left, so that side stays open just a little bit longer.
And finally, Section 5, Urogenital Emergencies and Tumors, Time-Critical Interventions.
For this final stretch, we're entering a realm where time literally equals tissue, and tumors have very specific, highly testable geographic behaviors. When you're sitting in your exam, I want you to hear my voice saying this: acute scrotal pain in a child is testicular torsion until proven otherwise. Full stop. There is absolutely no room for hesitation here.
The huge trap with suspected torsion is wanting to order a Doppler ultrasound, which delays care. If your clinical suspicion is high, you skip the imaging and go straight to surgical exploration. Waiting around for a scan can cost the child their testicle. The same urgency applies to an undescended testis. You have to fix it with an orchiopexy between 6 and 18 months of age.
The trap is picking any option that suggests waiting until after puberty. By that point, the damage to fertility and the significantly increased risk of malignancy is already set in stone.
Lastly, let's differentiate the two major pediatric abdominal masses. The midline of the body is your strict geographic boundary for these. Wilms tumor is the most common renal tumor. It's associated with WAGR syndrome, and it generally respects the midline. It stays on its own side. Neuroblastoma, on the other hand, is the most common extracranial solid tumor. Because it's derived from neural crest cells, it carelessly crosses the midline and pumps out catecholamines, which you'll see on a test as elevated VMA or HVA in the urine.
When we look at skin graft survival, the absolute most critical moment is right at 0 hours. A graft is literally going to fail if you place it on bare bone without periosteum or bare tendon without peritoneum. It absolutely needs that vascular bed. But what happens next is where they love to trap you. For the first 48 hours, the graft survives entirely by plasmatic imbibition, which just means it's soaking up nutrients directly from the wound bed like a sponge. Examiners will absolutely try to trick you into choosing inosculation for early survival. Don't fall for it. Inosculation, which is the actual linking of blood vessels, doesn't even kick in until days 2 and 3.
Let's break down exactly how examiners construct these traps. When a question asks for the most important factor in skin graft survival, your correct answer is always recipient bed vascularity. The bait? Immobilization. Sure, immobilization is important, but it means absolutely nothing if the bed has no blood supply. Next up, full thickness versus split thickness grafts. Full thickness grafts contract less and look way better cosmetically. But the trap here is thinking split thickness donor sites heal by primary intention. They don't. They heal by re-epithelialization from the remaining skin appendages. And finally, the classic baseline question. What fundamentally separates a flap from a graft? A flap carries its own blood supply. A graft doesn't. Simple as that.
So how do we choose the right flap? There's a really clear geometric rule here. Random flaps rely on unnamed subdermal plexuses, which heavily restricts them to a strict 1.5 to 2 to 1 length-to-width ratio. An axial flap, on the other hand, contains a specific named artery. That makes it incredibly reliable and frees it from those strict ratio limits. Clinically speaking, local flaps almost always fail in the lower third of the leg because the local tissue is just too poor, making a free flap the definitive correct choice. And if you're looking at breast reconstruction after a mastectomy, look for the latissimus dorsi or the TRAM and DIP flaps.
Okay, lock this number into your memory right now. 75. If you do a Z-plasty with limbs cut at 60-degree angles, you are going to increase the length of that scar by exactly 75%. It is a highly tested, incredibly common calculation on multiple choice exams.
And speaking of Z-plasties, never fall for the trap regarding their actual purpose. A Z-plasty is meant to lengthen a scar and change its direction, period. The trap answer they'll give you is scar excision. A Z-plasty does not remove a scar. In that same vein, you've got to strictly separate hypertrophic scars from keloids. A hypertrophic scar behaves itself. It stays neatly within the original wound margins. A keloid aggressively extends beyond them. Because of that, treating a keloid with just excision is a massive trap because it has an incredibly high recurrence rate. You need to use intralesional steroids and pressure. Oh, and as a quick bonus fact, when thinking about tissue breakdown, the sacrum is the most common site for a pressure sore, followed closely by the heel.
Moving right along to Section 2, hand injuries and deformities. Take a second to visualize this with me. In a boutonniere deformity, the proximal interphalangeal joint, or PIP, is flexed, while the distal interphalangeal joint, or DIP, is hyperextended. It is the exact anatomical opposite of the swan neck deformity, which has PIP hyperextension and DIP flexion. Examiners absolutely love testing this because the names alone don't give the anatomy away, making it super easy to mix up under pressure.
When you're presented with a hand case, there are a few absolute rules you can rely on. First, in Dupuytren's contracture, the ring finger is affected first, followed by the little finger. Second, a mallet finger is specifically an extensor tendon injury right at the DIP joint, which leaves the patient totally unable to extend that fingertip. On the flip side, if they can't flex the DIP joint, you've isolated the injury to the flexor digitorum profundus, or FDP. Just be careful not to confuse that with the FDS. Also, while you always need to watch out for cannibal signs because they point to a dangerous flexor tenosynovitis, standard paronychia is actually the most common hand infection overall.
Okay, major trap alert here. Listen closely. When diagnosing compartment syndrome, normal pulses do absolutely nothing to rule it out. I'll say that again. Pulses usually remain totally normal initially. The absolute earliest indicator you're looking for is pain completely out of proportion on passive stretch. Once you identify that, you can't just elevate the limb and hope for the best. It mandates an immediate urgent fasciotomy to release that pressure.
Section 3.
Burn management and resuscitation.
In early burn management, your sequence is everything. Step 1 is always your ABCDEs and aggressive fluid resuscitation. The exam trap will offer you topical antimicrobial creams right off the bat. Ignore them completely. Step 2, you have to rely strictly on an adult urine output of at least 0.5 milliliters per kilogram per hour to know if your fluids are actually working. Do not use blood pressure as your gauge. And step 3, if you've got tight, leathery, burned tissue causing vascular compromise, you need to perform an escharotomy.
The magic number for the Parkland fluid resuscitation formula is 4. 4 milliliters. You multiply 4 by the patient's body weight in kilograms, and then multiply that by the percentage of their total body surface area burned. You give half of that massive volume in the first 8 hours. But here's the trap. That 8-hour countdown starts at the exact time the burn occurred, not the time they rolled into your ER.
Now, depending on the cause of the burn, examiners love throwing curveballs. Clinically, blisters mean you're looking at a superficial partial thickness burn. Full thickness burns, surprisingly, are usually painless because the nerve endings are totally destroyed. Also, don't mix up your procedures. An escherotomy releases tight skin and circumferential burns, but a fasciotomy cuts deep into muscle for compartment syndrome. For electrical burns, the threat is all internal. Don't treat it like a thermal skin burn. The most common cause of death here is a fatal cardiac arrhythmia. And high-voltage shocks cause massive rhabdomyolysis, so keep a close eye on their CK and myoglobin to prevent kidney failure. Finally, chemical burns. They demand immediate, copious water irrigation. But there's one huge exception. If it's dry lime powder, you absolutely must brush it off the skin first before you add water, or you'll cause a massive exothermic reaction.
Let's jump into Section 4, bites, clefts, and cranial. Think about the mechanism of injury for a second. A standard dog bite gets irrigation and antibiotics, and if it's on the hand, we often just safely leave it open to heal. But a human bite over the metacarpophalangeal or MCP joint, what we call a fight bite, is incredibly dangerous. A human tooth striking that joint drives a nasty mix of bacteria deep into the joint space and the extensor tendon. Antibiotics alone won't cut it. This requires aggressive surgical debridement. Here is a really satisfying memory hook for pediatric reconstruction. To know the absolute best time to repair a cleft lip, strictly apply the rule of tens. The infant needs to be 10 weeks of age, weigh 10 pounds, and have a hemoglobin of 10 grams per deciliter.
While the cleft lip follows the rule of tens, the cleft palate is totally different, and it's an exam favorite. You have to repair a cleft palate strictly between 9 and 18 months. Why that specific window? Because the anatomy has to be fixed before the child develops speech to ensure they can phonate properly. While we're at it, remember that a cleft lip combined with a cleft palate is the most common anomaly overall. Shifting to the skull, sagittal synostosis, which causes that long, narrow head shape known as scaphocephaly, is your most common craniosynostosis. And just to be super clear on our terms, when we say microsurgery in this context, we specifically mean a free tissue transfer that strictly requires vascular anastomosis under a microscope.
Almost at the finish line. Section 5, high-yield exam traps. Let's bring it all together with a rapid-fire review of the biggest traps. They will give you a patient with a crushed leg and perfectly normal pulses to make you feel safe, but if there's extreme pain on passive stretch, it's compartment syndrome. Don't let them trick you into treating a keloid like a hypertrophic scar. Remember, hypertrophic scars respect the boundaries, keloids ignore them. Never confuse your tissue transfers. Flaps bring their own blood supply, grafts do not. Because of that, placing a graft on bare bone or bare tendon is a guaranteed failure. It needs periosteum or peritonon.
Continuing our TROP review, always start your Parkland fluid clock at the actual time of the fire, not the time of hospital admission. To see if those fluids are working, watch the urine output, not the blood pressure. If burned skin gets too tight, do an escharotomy, not a deep fasciotomy. And finally, never ever use a Z-plasty to excise a scar. It is purely a clever geometric tool used to lengthen and redirect the tissue.
All right, Section 1, Foundations and Donor Matching. So, examiners absolutely love to test your precision here. For instance, you probably know the kidney is the most commonly transplanted solid organ worldwide. But what's the most common indication? The exact correct answer you need to select is end-stage renal disease, or ESRD. The exam trap? They're going to offer diabetes as an option. And while diabetes is a massive underlying cause of kidney failure, the direct indication for the transplant itself is the resulting ESRD. Don't fall for it. Similarly, the cornea is the most commonly transplanted tissue overall, but you have to read the question carefully. The trap is picking cornea when they specifically ask for a solid organ. Keep those two categories totally separate in your mind. Now, organ preservation time is extremely high yield, and what's really interesting about this slide is the mnemonic built right into the timeline. You have to memorize the maximum cold ischemia time for each organ, so just look at the progression. Heart is 4 to 6 hours, liver is 8 to 12, pancreas is 12 to 18, kidney is 24 to 36. To lock this in quickly, just remember the multiples. Heart is roughly 4, liver is 12, kidney is 24. So the heart has the absolute shortest preservation time, while the kidney is the most resilient, giving surgical teams up to a day and a half.
Next up is the concept of brain death, which is honestly just full of clinical exam traps. The strict definition is the irreversible loss of all brain and brainstem function. The trap here is confusing this with a coma. They are vastly different. Plus, in many places, the clinical examination is the primary and completely sufficient method for determining brain death. Do not fall for the trap that confirmatory tests, like an EEG or a blood flow study, are universally required by law everywhere. Actually, scratch that assumption entirely. Finally, keep the physiological reality in mind. While the patient is legally dead, their heart might still be beating and organs might still be perfused, which is exactly what makes deceased organ donation possible.
Moving on to Section 2, Immunology and Organ Rejection.
Okay, take a breath. Immunology can be scary. But the most fundamental rule of transplant immunology is just this. A positive crossmatch is an absolute, strict contraindication to transplantation. Why? Because a positive crossmatch means the recipient already has preformed antibodies against the donor, which predicts a catastrophic hyperacute rejection. So when a question asks you for the best baseline compatibility, you are looking for two mandatory things. The patient must be ABO blood type compatible, and they must have a negative crossmatch. While HLA matching is super important for long-term success, ABO compatibility and a negative crossmatch are your absolute vital baselines.
Let's systematically break down the three types of rejection. It's kind of like a timeline puzzle. Hyperacute rejection happens incredibly fast, literally in minutes to hours. It's caused by those preformed antibodies we just talked about. And the crucial exam point, it cannot be reversed. You have to surgically remove the graft. Next is acute rejection, which pops up over days to months. This one is T-cell mediated, and the really good news here is it's highly treatable with high-dose corticosteroids. Finally, we have chronic rejection, happening over months to years. Its mechanism involves fibrosis and vascular changes, and sadly, it's generally irreversible, most often requiring a completely new transplant.
To prevent all that rejection, we use immunosuppressants. And test writers love testing your knowledge of specific drug side effects. Tacrolimus is the most commonly used calcineurin inhibitor today. But listen, if you see a question describing a transplant patient with new-onset swollen gums, that's gingival hyperplasia, and extra hair growth, or hirsutism, they absolutely want you to pick cyclosporin. Mycophenolate mofetil and azathioprine both cause bone marrow suppression. For sirolimus, your classic board clue is a patient presenting with delayed wound healing or high lipids. And of course, prednisone comes with all the classic long-term steroid complications you already know, like osteoporosis and diabetes.
All right, doing great. Section 3, Specific Solid Organ Transplants.
So the crucial point when it comes to the kidney is understanding exactly where the surgeon places it. The correct board answer is the iliac fossa, and importantly, it is placed extraperitoneally. You do not go into the main abdominal cavity. Another trap? Thinking those old, failing kidneys need to come out? Actually, the native kidneys are usually left right where they are unless there's a specific issue, like massive polycystic kidneys or a severe infection. Finally, remember the vascular plumbing here. The new renal artery is standardly anastomosed to either the external or internal iliac artery.
Moving up to the liver, how do we decide who gets a liver first? The MELD score. That is your high-yield answer for prioritization, for sure. Now, what's the most common early complication right after surgery? Students frequently jump to cirrhosis as an indication or biliary leak as a complication, mostly because bile ducts are famously tricky to sew together. But those are traps. The MELD score dictates priority, and the actual most common early complications are primary graft dysfunction, meaning the new liver just isn't waking up, or vascular complications like hepatic artery thrombosis.
For the heart, the indication is pretty obviously end-stage heart failure. But here is a massive trap. If a patient dies years after a successful heart transplant, what caused it? The immediate instinct is to pick chronic rejection, but the specific correct board answer is cardiac allograft vasculopathy. It's an accelerated form of coronary artery disease that is totally unique to transplanted hearts. As for the pancreas, the classic presentation is a patient with type 1 diabetes who has also developed end-stage renal disease. The highest yield procedure for this patient is an SPK, a simultaneous pancreas-kidney transplant.
Almost there. Section 4. Post-transplant complications. And this brilliantly illustrates the timeline of infections, because post-transplant infections follow a highly predictable schedule. You really want to memorize these distinct phases. In the first month, the patient is recovering from major surgery, so they get standard bacterial or surgical site infections. But from month 1 to month 6, the immunosuppression is at its absolute peak. This is the danger zone for opportunistic infections, most notably viruses and fungi. Once we finally get past that 6-month mark, their drug doses are usually lowered, and they're back out in the real world, so they tend to catch typical community-acquired infections like routine pneumonias.
Speaking of that 1 to 6 month window, cytomegalovirus, or CMV, is the absolute most common opportunistic infection after a solid organ transplant. The boards will likely describe a patient a few months out with a fever, neutropenia, and maybe some GI or respiratory symptoms. When you see that, you must lock in ganciclovir or its oral prodrug valganciclovir as the absolute standard drug of choice for both treating and preventing CMV on the boards.
Section 5. High-Yield Rapid Review.
You are doing so great. As your study buddy, I want to make absolutely sure no points slip through the cracks here at the end. So, what does this all mean when you face those tricky, debatable questions? Like, what is the absolute best immunosuppressant? And who exactly makes the very best donor? Let's prime your brain for these nuanced exam approaches right now.
Here is exactly how you resolve the debate. For the best regimen, modern exams are looking for the current gold standard, a combination of tacrolimus, mycophenolate, and steroids. However, if you're doing an older test bank or an exam that hasn't quite updated its questions, they might still force you to pick cyclosporin as a standalone historically significant drug. You kind of just have to read the room of the question. As for the donor, while a compatible deceased donor is the most common practical reality, if they ask for the absolute best physiological outcome, your answer is always an HLA-identical living-related donor.
Okay, let's fire off these super high-yield one-liners to cement our foundations. The kidney is your most common solid organ, while the cornea is your most common tissue. The kidney is super tough, boasting the longest cold ischemia time at 24 to 36 hours. The heart, on the other hand, is incredibly delicate, with the shortest preservation time at just 4 to 6 hours. And never, ever forget, a positive cross-match means preformed antibodies are present, which strictly contraindicates the transplant. No way around it.
Continuing our exhaustive review, hyperacute rejection happens immediately and requires the surgeon to take the graft right back out. Acute rejection is treated aggressively with high-dose corticosteroids. Chronic rejection is progressive and sadly irreversible. When it comes to the drugs, tacrolimus is your go-to modern calcineurin inhibitor. And for surgical placement, that brand new kidney is nestled extraperitoneally right down in the iliac fossa, connected to the iliac vessels.
Let's move to the end and see how this builds our final clinical picture. The MELD score is your metric for liver transplant priority. CMV is the opportunistic infection you absolutely must watch out for between months 1 and 6. Your safest baseline for a happy graft is ensuring the patient is ABO compatible, with a negative cross-match. Finally, the simultaneous pancreas kidney transplant, or SPK, is the classic board procedure for a patient suffering from both type 1 diabetes and end-stage renal disease.
All right, let's jump right into Section 1, ICU Basics and Sepsis. Notice right away how quickly outdated thinking gets exposed here. For instance, what's the most common cause of ICU admission in surgery? The correct clinical answer is sepsis. Trauma is a really frequent exam trap based on older teaching, but it actually ranks second in most centers today. And look at the markers for perfusion. Serum lactate and a urine output of greater than or equal to 0.5 milliliters per kilo per hour are your true north for adequate resuscitation. Relying on blood pressure alone, classic trap. Finally, note that a normal central venous pressure, or CVP, is 2 to 6 millimeters of mercury. Please don't fall for those older exam questions that quote 5 to 10 centimeters of water. The absolute key takeaway here is that a normal blood pressure can completely falsely reassure you. A patient might be compensating perfectly well on the surface, but an elevated lactate always reveals the hidden shock happening down at the cellular level. It's kind of like looking under the hood of a car. The outside might look fine, but the engine is overheating. Looking at the modern Sepsis 3 guidelines, we see a major shift.
sepsis is no longer just a systemic inflammatory response. It's officially defined as life-threatening organ dysfunction due to a dysregulated host response to infection. But I want you to pay very close attention to septic shock. The exam trap is thinking that low blood pressure alone defines it. No way. The absolute requirement for defining true septic shock is the need for vasopressors to maintain a mean arterial pressure, or MAP, of 65 or higher, alongside an elevated lactate, even after you've already given them adequate fluids.
So let's track this sequentially on our timeline, because timing is everything. At time 0, your job is simple: recognition. Within the first 1 to 3 hours, you must fluid resuscitate aggressively. We're talking 30 milliliters per kilo of crystalloids. Now, if the patient is still hypotensive after that massive fluid challenge, you move to hour 3 and reach for norepinephrine as your first-line vasopressor to hit that target MAP of 65. This sneaky exam trap here, selecting dopamine. Don't do it. Norepinephrine is always going to be your go-to.
Moving right along, Section 2, Mechanical Ventilation and ARDS.
You know, the most common indication for mechanical ventilation is actually super broad. It's general respiratory failure, rather than just isolated hypoxemia or hypercapnia. This really highlights the vital distinction between oxygenation and ventilation. To monitor ventilation, you absolutely must rely on end-tidal CO2, or capnography, because it measures exhaled air, which confirms actual gas exchange. Pulse oximetry only tracks oxygenation, making it a very, very common exam trap. Now, when we look at acute respiratory distress syndrome, or ARDS, the most common cause is sepsis. That catches out a lot of students who guess trauma or aspiration. And the true hallmark of ARDS? It's refractory hypoxemia. That means their oxygen levels just will not improve, even when you're blasting them with 100% oxygen.
Let's talk about settings. Standard ventilation typically uses tidal volumes of 6 to 8 milliliters per kilo of predicted body weight. But because ARDS demands a lung protective strategy, you must strictly drop that tidal volume down to exactly 6 milliliters per kilo. This minimizes pressure and prevents further barotrauma to those fragile lungs. Also, keep in mind there's no magic drug to cure ARDS. You simply support the lungs with those low tidal volumes and aggressively treat the underlying cause. Okay, Section 3, Fluids and Acid-Base Disorders. This part is fascinating because it highlights some major paradigm shifts in critical care. If an exam question feels a bit outdated, your alarm bells should be ringing. The old traps will try to push you toward normal saline as the default fluid and using CVP for fluid assessment. Don't take the bait. The modern correct approach heavily favors balanced crystalloids like Ringer's lactate to avoid hyperchloremic metabolic acidosis. Furthermore, those static CVP measurements, they've been totally replaced by dynamic assessments, like the passive leg raise. And keep in mind, crystalloids are strictly your first-line therapy. Colloids, like albumin, are highly restricted for very specific situations. Understanding exactly when to use alternative fluids is absolutely crucial. Hypotonic fluids, like 0.45% saline, are great for maintenance or a pure water deficit, but they have absolutely zero place in shock resuscitation. Giving them to a hypotensive patient is a dangerous trap. On the other end of the spectrum, hypertonic 3% saline is a heavy hitter. It's reserved exclusively for severe, symptomatic sodium crashes, and it requires super careful monitoring. You definitely don't want to rush that one. When it comes to acid-base disorders, just keep it systematic. The most common metabolic acidosis in shock is lactic acidosis, which, as we just covered, directly reflects that poor tissue perfusion. Conversely, we can systematically trace metabolic alkalosis straight back to the loss of gastric acid, usually from severe vomiting or an NG tube constantly suctioning. For the respiratory side, always look directly at your PaCO2 levels. High PaCO2 means the patient is hypoventilating and holding on to all that acid. Low PaCO2, they're hyperventilating and blowing it off. For daily maintenance on the wards, you just need to burn these clean, exact baseline numbers into your brain for your adult patients. They need 25 to 30 milliliters per kilo of water, roughly 1 millimole per kilo of both sodium and potassium, and 50 to 100 grams of glucose per day. Knowing these simple numbers prevents some incredibly common errors. Because think about it, accidental fluid overload can easily lead to pulmonary edema, while nutritional starvation severely delays wound healing in the hospital. All right, Section 4, Critical Electrolyte Imbalances. Let's dive in. So, hyponatremia is actually the most common postoperative electrolyte disorder. This is usually due to the release of antidiuretic hormone, or ADH, triggered by the stress of surgery itself. The trap here, correcting that sodium too rapidly. That severely risks osmotic demyelination syndrome, which is devastating. Now, if a patient just had a thyroidectomy, watch out for hypocalcemia due to accidental parathyroid damage. You'll classically see this as a Trousseau or Chvostek sign. Watch for that facial twitch or wrist spasm. And here is a highly tested secret. You simply cannot fix a refractory low potassium until you've successfully replaced their magnesium first. Oh, and always remember to give magnesium sulfate for torsades de pointes, even if the lab says their magnesium level is completely normal. Speaking of potassium, let's quickly look at the extremes. For hypotassium, or hyperkalemia, you always want to look for those tall, peaked T waves on the ECG. That is your earliest life-saving warning sign. The exam trap is thinking widened QRS complexes happen first. Actually, scratch that. They don't. The peaked T waves do. On the flip side, the most common cause of hypokalemia is usually diuretics or GI losses, which are, as you'd guess, extremely common in surgical and ICU scenarios. When you are facing severe hyperkalemia, you must follow these exact steps. Step 1 is always administering IV calcium gluconate. Now, this doesn't actually lower the potassium. Rather, it stabilizes the cardiac membrane to prevent a lethal arrhythmia. Only after the heart is protected do you move to step 2, which is administering insulin and glucose, or beta-2 agonists, that physically shifts the potassium out of the blood and into the cells. Reversing this order is a fatal exam trap, so keep it straight. Finally, we've made it to Section 5, renal support and refeeding. With refeeding syndrome, you absolutely must understand the hallmark sign, plummeting phosphorus, or hypophosphatemia. Here's what happens. When a starved patient receives sudden nutrition, their insulin spikes, which drives phosphate into the cells and dangerously depletes their blood levels. The trap is thinking you should just blindly replace all their electrolytes, but the correct prevention strategy is actually to reintroduce nutrition very, very slowly and always administer thiamine alongside it. Okay, here are the absolute indications for dialysis using the classic AIOU mnemonic: acidosis, electrolyte imbalance, intoxication, fluid overload, and uremia. It's a great tool, but pay really close attention to the E. The exam trap is thinking any high potassium needs dialysis. In reality, the hyperkalemia must be refractory to our earlier medical steps, meaning if the calcium, insulin, and glucose didn't work, only then does it qualify as an absolute indication to hook them up to the dialysis machine.
Pre-op and airway management. So our journey actually starts before the patient even rolls into the operating room. In this first crucial phase, our main goals are assessing their baseline health and ensuring we can securely manage that airway.
Right off the bat, a total cornerstone of preoperative assessment is the ASA classification system. Examiners absolutely love this one. ASA-I is your healthy patient with no systemic disease. ASA-2 means mild systemic disease, think well-controlled diabetes. ASA-3 steps it up to severe systemic disease with functional limitation. But right here, pay super close attention to ASA-4, severe disease that is a constant threat to life. That specific phrasing? Total Viva exam trap. Commit that exact definition to memory. And finally, ASA-5 is a morbid patient not expected to survive without the surgery.
Now, before we move forward, I want you to think about this real quick. What is the most common cause of difficult intubation? Got an answer in your head? Well, let's see if you just fell into a trap.
So if your brain went straight to airway assessment, you definitely fell for a classic trap. The actual most common cause of difficult intubation is specifically a poor laryngoscopic view. Usually we're talking a Mallampati Class 3 or IV. Looking at a few more high-yield concepts here, notice that the gold standard airway is endotracheal intubation, not just some generic definitive airway. Also, that Mallampati classification is your absolute best predictor of difficulty. And heaven forbid, if you're in a failed intubation scenario where you literally cannot ventilate, do not keep trying to force the tube. The correct exam answer, and honestly the real-life answer, is to go straight for an emergency cricothyrotomy.
And this brilliantly illustrates one of the absolute most critical safety checks in anesthesia. Once you actually place that endotracheal tube, how do you know for sure it's in the trachea and not sitting in the esophagus? The undisputed gold standard is end-tidal CO2, otherwise known as capnography. Seriously, don't let the exam tempt you into picking auscultation. Listening with a stethoscope is helpful, sure, but physically detecting that CO2 is the absolute, unquestionable gold standard.
All right, moving on to Section 2, induction and muscle relaxants. Our patient is fully assessed, we've got an airway plan, so it's time for induction. This is where we safely transition them into an anesthetic state and manage their muscle relaxation.
When we're picking induction agents, context is literally everything.
Propofol is the most common IV agent by far. You'll see it everywhere. But the trap is forgetting that it causes hypotension. So what if your patient rolls in with shock and they're hemodynamically unstable? You're going to switch to etomidate because it causes minimal cardiovascular depression. What if they have a history of severe asthma? Bam! Ketamine is your answer because it acts as a bronchodilator. And for inhalational induction, sevoflurane is the go-to, mostly because of its really pleasant smell and super rapid induction profile.
And when we talk about rapid sequence induction, or RSI, we run right into this massive collision between older exam teaching and modern evidence. Historically, succinylcholine was the only correct answer for an RSI muscle relaxant because nothing could beat its speed. But modern evidence, and honestly newer exam formats, recognize high-dose rocuronium as a totally safe, acceptable alternative, especially if you need to avoid succinylcholine side effects. So you've kind of got to read the room on your exam here. If it's an older syllabus, definitely lean towards Sux.
The reason succinylcholine is such a classic favorite basically comes down to its totally unique profile. It's actually the only commonly used depolarizing muscle relaxant. It has the fastest onset of any relaxant, literally taking effect almost immediately, and just as importantly, it's got a really short duration. We're talking just 5 to 10 minutes. So if you were to lose the airway, the patient will actually recover their own spontaneous breathing pretty fast.
Section 3. High-yield intraoperative emergencies. Okay, our patient is asleep, but surgery can be wild. We need to maintain a calm, totally prepared mindset for these next emergencies. Knowing these cold will save lives and for sure score you major points.
Let's talk about every anesthesiologist's nightmare, malignant hyperthermia. This is an autosomal dominant inherited ryanodine receptor defect. It's triggered by the exact drugs we were just talking about, succinylcholine combined with volatile anesthetics. It's also heavily associated with central core disease. But here's the crucial point for your test. The earliest sign is a rapid rise in end-tidal CO2, not a fever. The fever actually happens way later. So if you see that unexplained EtCO2 spike, you immediately stop the triggers and hit them with the definitive treatment, dantrolene.
Another totally dire emergency is local anesthetic systemic toxicity. Now, lidocaine is a very common, short-acting agent, but bupicaine is notoriously the most cardiotoxic. If a large dose of bupicaine accidentally gets into the bloodstream, it can cause catastrophic cardiac arrest. The modern standard antidote that you absolutely must select on your exam is a 20% lipid emulsion.
On to Section 4, Local and Regional Anesthesia. Speaking of local anesthetics, let's just smoothly transition into how we use these for regional blocks, either as the primary anesthetic or for really excellent post-op pain relief.
Okay, here is perhaps one of the most famous medical myths and massive exam traps in history, using adrenaline in fingers, toes, noses, and hoses. Older exams are going to rigidly expect you to say you must absolutely avoid adrenaline with local anesthetics in digits to prevent necrosis. No exceptions. But modern medical evidence has actually proven that highly dilute epinephrine can totally be used safely in selected patients. Again, you have to know your examiner. If you're taking a traditional board exam, definitively tick that avoid adrenaline box to be safe.
When you're doing central neuroaxial blocks, safety is the name of the game. Spinal anesthesia must be injected safely below where the spinal cord actually terminates, which is exactly why we use the L3, L4, or L4, L5 spaces. If you're placing an epidural, the classic technique to identify that space is loss of resistance. Now, what happens after you give a spinal? Well, the most common complication by far is hypotension, and that's due to a sympathetic block. And what if they develop a brutal post-dural puncture headache a day later? The definitive gold standard treatment for that is an epidural blood patch.
Section 5. Monitoring and post-op complications. The surgery's wrapping up, we're reversing the anesthesia and bringing our patient into their final critical phase, waking up safely and navigating that immediate post-op period.
Vigilance is our absolute best tool here in recovery. Pulse oximetry is your completely mandatory intraoperative monitor for oxygenation. For ventilation, capnography remains your gold standard, with a normal EtCO2 sitting right between 35 and 45 millimeters of mercury. If you're looking to monitor tissue perfusion, you want to look at blood pressure and urine output together. And remember, if a patient is hypoventilating in the recovery room, it is directly going to cause hypercapnia, a dangerous rise in their CO2 levels.
Now, what's really interesting about this slide is seeing just how firmly entrenched some medical dogma is. If a patient spikes a fever on post-op day 1, traditional exams will practically demand that you answer atelectasis. The reality? Modern rigorous evidence strongly questions this whole association, suggesting atelectasis doesn't actually cause the fever at all. But please, be incredibly careful here. A lot of exam answer keys haven't caught up to this reality yet. So for the test, day 1 fever still equals atelectasis.
Let's check out a few more immediate complications. The absolute most common cause of airway obstruction right after waking up isn't some complex hematoma, it's simply the patient's relaxed tongue falling backward. And while atelectasis might not cause a fever, it is absolutely the most common cause of post-op hypoxemia. Lastly, postoperative nausea and vomiting, or PONV. This is a massive source of patient distress, and the risk factors really stack up here. Being female, the use of volatile anesthetics, and postoperative opioids are among the very highest predictors.
All right, let's do a rapid-fire review to cement these one-liners straight into your short-term memory before test day. Ready? Capnography is the gold standard for tube placement. Propofol causes hypotension. Etomidate is for the hemodynamically unstable. Ketamine is for the asthmatic. Succinylcholine is your fastest relaxant. Treat malignant hyperthermia with dantrolene. Bupivacaine is highly cardiotoxic. And always do your spinal safely down at L3 to L5. These are your absolute non-negotiable facts.
All right, Section 1, General and Enteral Nutrition, covering screening and feeding basics. This is the foundation of everything that follows, so let's get right into it. Right off the bat, let's talk about nutritional screening. When you see a question asking for the most reliable bedside screening tool, remember the word MUST. That stands for Malnutrition Universal Screening Tool. The examiners are almost certainly going to dangle the NRS 2002 in front of you as a sneaky distractor. Don't fall for it. MUST is your correct answer. Now, what's really interesting here is a classic generational shift in medicine. Test writers notoriously love to use albumin as a distractor for the best marker of nutritional status. Older exams actually used to consider albumin the gold standard. But modern evidence proves that albumin mainly reflects acute inflammation, sepsis, or liver disease rather than just pure malnutrition. So when they ask for the most important marker, you'll confidently and correctly choose recent unintentional weight loss. And that brings us to our absolute golden rule, a phrase you should literally be repeating to yourself during the exam. If the gut works, use it. You should always choose enteral nutrition, meaning feeding through the GI tract, over parenteral nutrition whenever it's feasible. And yes, this applies even if the gut is only partially working. It's so important because it maintains the gut mucosa and prevents bacterial translocation. That golden rule directly builds our clinical timeline for enteral feeding. If your patient needs to be fed for less than 4 to 6 weeks, the preferred route is a nasogastric, or NG tube. The only exception there is if their aspiration risk is incredibly high. But as soon as we cross that 4 to 6 week threshold, you absolutely must transition your patient to a PEG tube for long-term feeding. You have to be super careful here because we need to contrast two heavily tested nuances. First, an absolute contraindication to enteral feeding is a mechanical bowel obstruction or intestinal ischemia. The pitfall they'll use is a paralytic ileus, which is actually usually just a relative contraindication. Second, while aspiration is certainly the most serious complication of enteral feeding, diarrhea is actually the most common. Always read the question carefully to see if they're asking for the most common or the most severe. But as we all know, sometimes the gut just doesn't work. That brings us to Section 2, Parenteral Nutrition and Risks. Basically, what to do when the gut fails. The crucial takeaway here is that you should avoid unnecessary TPN. You want to reserve it strictly for when the gastrointestinal tract is entirely non-functional or anatomically inaccessible. The exam pitfall? Suggesting TPN just because a patient can't eat on their own or refuses meals. If their gut works, we use enteral tubes. TPN is strictly a last resort. Let's break down the TPN essentials you absolutely must have memorized. Because TPN is a highly hyperosmolar solution, your preferred access has to be a central venous catheter. If you tried it peripherally, it would just destroy the veins. And because you're using this central line, your most common complication is a catheter-related bloodstream infection. Also, really know your macros. The main carbohydrate source is dextrose, and the lipid source is an intravenous lipid emulsion, which provides those essential fatty acids. Moving right along to Section 3, the refeeding syndrome. This is the most dangerous metabolic complication, and it definitely deserves our full attention. Here's what happens. When a starved patient suddenly receives glucose, their body releases a massive surge of insulin. This insulin forcefully drives glucose into the cells, but it drags electrolytes right along with it. The absolute hallmark abnormality you need to look for on your exam is hypophosphatemia, a sudden, sharp drop in serum phosphate. But don't let them trick you by ignoring the others. That same insulin surge also profoundly tanks your potassium and magnesium levels.
To prevent this potentially fatal mistake, both in clinical practice and on your boards, you must methodically follow 3 steps. Step 1, never start full calories immediately. You have to start feeds very slowly. Step 2, and this is incredibly high yield, always replace thiamine before or right at the start of feeding to prevent Wernicke's encephalopathy. And step 3, aggressively monitor and replace those vital electrolytes, phosphate, potassium, and magnesium.
Now that we know how to feed safely, let's shift gears to Section 4, macros, vitamins, and minerals. These are the building blocks of recovery.
Remember, surgical patients are not like your average healthy adult. Notice how a healthy adult needs about 0.8 to 1 gram of protein per kilogram a day. But after major surgery or major trauma, increased catabolism bumps that daily protein requirement all the way up to 1.2 to 2 grams per kilogram. Their baseline energy requirement sits at roughly 25 to 30 kilocalories per kilogram a day, though as we'll see in a minute, severe burns push this even higher.
This next concept brilliantly illustrates how we monitor that nutritional support. Take a look at the half-lives. Prealbumin has a rapid half-life of just 2 to 3 days, making it vastly more useful for short-term monitoring of acute nutritional changes. Albumin, on the other hand, has a really sluggish 20-day cycle. Just keep in mind, as we touched on earlier, both of these markers will erroneously drop in the presence of inflammation or sepsis, which is exactly why they can be tricky.
These nutrient deficiencies are absolute pure gold for your board prep. You really need to cement the pathophysiology behind them. Vitamin C deficiency leads to poor wound healing because it's essential for collagen synthesis. Vitamin K deficiency causes bleeding by impairing clotting factors 2, 7, 9, and 10. Vitamin A is linked to night blindness. And definitely don't forget zinc. Its deficiency causes delayed wound healing and, uniquely, a loss of taste. Lastly, you should frequently expect iron deficiency anemia after major GI surgeries.
Let's apply these rules to 3 really heavily tested areas. Section 5, specific surgical scenarios. We'll look at burns, short bowel, and immunonutrition. First up, major burns. Burn patients exist in a massive hypermetabolic state, so the correct answer is always, early enteral feeding with exceptionally high protein and calorie requirements. Providing this early nutrition is vital because it actually reduces bacterial translocation from the gut, which ultimately protects the patient against sepsis. The common mistake test makers use is delaying feeding or severely underestimating just how many calories these patients actually need.
Next is short bowel syndrome. The classic exam vignette here will mention a terminal ileum resection. Whenever you see terminal ileum, immediately start scanning your answer choices for vitamin B12 and bile salt malabsorption, because that's exactly where they're absorbed. The trap here is assuming a uniform treatment for all short bowel patients. Treatment has to be individualized. Enteral is preferred if enough bowel remains, but severe cases will inevitably require TPN.
Our third scenario is immunonutrition. This involves specialized formulas enriched with components like arginine, glutamine, and omega-3 fatty acids. These are totally excellent for reducing postoperative infections in patients undergoing major elective surgery. However, the pitfall is thinking there's some magical cure indicated for every single patient. They're absolutely not. They are used very selectively.
You have done wonderfully so far. We're at Section 6, High Yield Final Review. This is your ultimate exam cheat sheet. Think of this as the rapid-fire one-liners you absolutely must walk into the exam room with.
Just relax and let these bullet points wash over you. Ready? If the gut works, use it. TPN demands central venous access, and a catheter-related infection is your biggest enemy. Hypophosphatemia is the unmistakable hallmark of refeeding syndrome. Always start severely malnourished patients slowly and make sure to give thiamine. Remember that vitamin C and zinc are for wound healing, while vitamin K is for clotting. Major burns demand early aggressive enteral feeding. And finally, prealbumin beats albumin for short-term monitoring. These are the core concepts that literally separate a passing
Part
score.
1, preoperative assessments and fasting.
Let's kick things off with a foundational concept that trips up so many students, the ASA classification. Listen closely. The ASA score strictly assesses a patient's perioperative physical status. It's all about their systemic health. The classic exam trap, trying to link this score to the complexity of the surgery itself. Absolutely do not fall for it. A completely healthy patient going in for a massive complex 10-hour surgery is still an ASA 1. Just keep those two concepts separate in your mind.
And this right here brilliantly illustrates how examiners test your clinical judgment. If you're asked for the most important preoperative assessment, your reflex should always be a thorough history and physical exam. The trap? They'll tempt you with a huge battery of routine lab tests. Skip them. Always stick to the history and physical. When it comes to cardiac risk, the absolute best predictor is functional capacity, which we measure in METs. That is a massively tested concept. For postoperative pulmonary complications, you want to look for smoking and pre-existing lung disease. Examiners will dangle advanced age as a decal, but it's the specific lung history that actually matters.
Okay, moving on to the strict timeline of preoperative fasting. Honestly, this is pure memorization, but it's super essential. The timeline scales up really smoothly, 2, 4, 6, and 8 hours. At 2 hours before surgery, clear fluids are totally fine, which actually aligns perfectly with modern enhanced recovery standards. At 4 hours, breast milk is allowed. That's a really frequent pediatric question, by the way. At 6 hours, we're looking at infant formula or a light meal. But pay close attention to the 8-hour mark. A fatty meal requires a full 8 hours of fasting, simply because fat significantly delays gastric emptying. Moving right along to part 2, prophylaxis, antibiotics, and VTE. When it comes to antibiotics, timing is literally everything. The absolute best timing for standard prophylaxis is within 60 minutes before the surgical incision. But watch out for the pitfall. Certain drugs, like vancomycin or fluoroquinolones, need a longer infusion time and might have to be started up to 120 minutes prior. Now, the most commonly used antibiotic across the board? That's cefazolin, a first-generation cephalosporin. And here's a highly tested scenario for you. When do you give a repeat dose? Well, you have to redose if it's a super long operation, meaning it exceeds 2 half-lives of the drug, or if the patient has had major blood loss.
Let's talk about venous thromboembolism, or VTE. The best prevention strategy is a combo of early mobilization and low molecular weight heparin, tailored to a risk-based approach. You really need to know which patients are at the absolute highest risk here. A super common question will point you toward patients undergoing major orthopedic surgeries, think hip or knee replacements, or pelvic cancer surgeries. Those patients are prime targets for VTE. Now, what's kind of fascinating here is the tension between modern clinical practice and older exam questions. If a patient develops a suspected DVT today, the modern gold standard and best initial test is a duplex compression ultrasound. But some older historical exams considered contrast venography the gold standard. So when you sit for your exam, just recognize that unless they specifically ask about historical context, ultrasound is for sure the correct diagnostic tool to pick.
All right, on to part 3, fluids and blood transfusions. Here's another highly debated topic that is just a trap waiting to happen. What's the preferred initial resuscitation fluid? Modern medical practice strongly favors balanced isotonic crystalloids, like Ringer's lactate. Why? Because they're way closer to physiologic plasma and help prevent hyperchloremic metabolic acidosis. But older exams used to trick students into picking normal saline. While normal saline's okay in a few specific situations, current practice and modern exams lean heavily toward Ringer's lactate for initial volume resuscitation. So as you're resuscitating that patient in the OR, how do you actually know if you're giving enough fluid? The single best indicator of adequate resuscitation and renal perfusion is urine output. You are looking for a bare minimum of 0.5 milliliters per kilogram per hour in an adult. You also need to keep a really close eye on their electrolytes. The most common postoperative electrolyte disorder is hyponatremia. Basically, the surgical stress response triggers the release of ADH, antidiuretic hormone, which makes the body hold onto free water, diluting the serum sodium. Now, if fluids aren't cutting it and you need blood, you've got to know your transfusion facts cold. The universal donor for red blood cells is O negative. That's what you grab in a massive uncross-matched emergency. The universal recipient, AB positive. Now, for the reactions, pay really close attention to the adjectives the exam uses. The most common overall transfusion reaction is a febrile non-hemolytic reaction, but the most serious acute reaction is an acute hemolytic transfusion reaction, usually caused by a deadly ABO incompatibility. Don't mix those two up.
Let's move into part 4, postoperative fever and complications. Examiners absolutely love testing the postoperative fever timeline. Within the first 24 hours, the classic answer has always been atelectasis, even though we now know inflammation plays a huge role. Moving to days 3 through 5, you really want to be looking closely at the wound for a surgical site infection. And as we push out to days 5 through 7, your suspicion should shift heavily toward a DVT or a pulmonary embolism. I want to pause here and really highlight this day 1 fever debate.
because it's honestly one of the most frustrating traps for students. Modern evidence clearly shows that early fever within the first 24 hours is overwhelmingly just the body's natural inflammatory response to the trauma of being cut open. But the traditional, deeply entrenched exam answer is atelectasis. So if you're taking a standardized test and get a question about a day 1 fever, you often still have to click atelectasis. Know the actual science, but definitely play the exam game carefully here. Aside from fever, what other complications pop up? Well, the most common pulmonary complication is, once again, atelectasis. The most common cardiac complication is atrial fibrillation, especially after thoracic or cardiac procedures. Now, if your post-op patient has tachycardia, the 2 most common causes you've got to assess first are pain and hypovolemia. Similarly, if they develop oliguria, that's low urine output, hypovolemia is your prime suspect. But a quick tip, always check their catheter first to exclude a simple mechanical obstruction. When you're assessing surgical wounds, remember that the most common bug responsible for a clean surgical site infection is Staphylococcus aureus. That is incredibly high yield. If a wound does become infected, the best management is to open it up and allow for drainage. The classic exam trick is giving you an answer choice suggesting you should primarily close an infected wound. Literally never do that. Also, keep in mind that the very first sign of a wound infection is usually increasing pain and erythema, and that shows up way before you see any actual purulent discharge.
Okay, part 5, recovery, ERAs, and pain management.
You are definitely going to see questions on ERAS, which stands for Enhanced Recovery After Surgery. This is a massive paradigm shift in perioperative care. The key principles here are early feeding and early mobilization. We just don't starve patients for days after bowel surgery anymore. On top of that, ERAS dictates that we avoid routine, prolonged use of nasogastric tubes and Foley catheters. Getting those tubes out early dramatically lowers the risk of complications, especially UTIs.
So the crucial point here is that pain management has evolved, too. The absolute best postoperative analgesia is now a multimodal approach. By combining Tylenol, NSAIDs, and regional blocks, we can significantly cut down on opioid use and all those nasty side effects. A classic board question asks for the best pain control, specifically after a thoracotomy. The answer you want is a thoracic epidural analgesia. And if you see the abbreviation PCA, that's patient-controlled analgesia. It's basically an IV opioid delivery system that empowers the patient to safely manage their own breakthrough pain.
And finally, Part 6, High-Yield Exam Review.
Let's lock these concepts in right now. History and physical exam beat out routine labs every single time for pre-op assessment. The ASA classification predicts risk purely based on physical status, not the surgery itself. Make sure you give those prophylactic antibiotics within that strict 60-minute window before the incision. Trust a urine output of at least 0.5 milliliters per kilogram per hour as your guide for adequate renal perfusion. Rely on early mobilization and LMWH as your cornerstones for VTE prevention. Remember that Staphylococcus aureus is the top culprit for clean surgical site infections. Always opt for multimodal analgesia to manage pain safely. And finally, ERAS is all about minimal fasting, early feeding, and getting that patient up and moving.
Section 1, Soft Tissue Surgical Infections. Let's jump right into these everyday surgical encounters.
So, when you're evaluating surgical site infections, Staphylococcus aureus is your classic go-to answer for clean surgery, right? But you really have to watch out for the colorectal surgery trap. Never pick a single organism there. The correct answer is always going to be the mixed flora of E. coli and Bacterovagilus vagilis. And here's another thing. When you're looking at risk factors, don't just search for a lack of antibiotics. Poor glycemic control actively impairs wound healing, and that is a major, highly tested risk factor right alongside wound contamination.
Now, the ultimate trap for SSI prevention isn't just about choosing the right drug. It's entirely about timing. Antibiotic prophylaxis literally must be administered within a strict 60-minute window prior to the surgical incision. If you give it at the exact moment of surgery or postoperatively, you've completely missed the prevention window. Timing is everything here.
When assessing necrotizing soft tissue infections, the phrase you need to permanently burn into your brain is pain out of proportion. That is your earliest, highest yield clue. And while Group A strep is the most common organism, remember it can totally be polymicrobial. But the biggest trap of all is relying on medication. Antibiotics alone are fundamentally insufficient here. The definitive gold standard is emergency surgical debridement. Yes, we add clindamycin because it helps halt toxin production, but it never ever replaces the scalpel.
Moving on to gas gangrene. This one is caused by the anaerobic gram-positive Bacillus Clostridium perfringens. The clinical hallmark you're hunting for is crepitus combined with muscle necrosis, not just gas in the tissues. And please, avoid the definitive treatment trap. Do not jump straight to amputation. The correct first step is urgent debridement paired with high-dose penicillin.
You know, treatment distinctions between common skin conditions are a massive favorite for exams. It's like a treatment ladder. Cellulitis? Generally managed with antibiotics. But if an abscess forms, that strictly dictates an incision and drainage. Antibiotics alone will just fail. Now, for diabetic foot infections, which are usually chronic and polymicrobial, you need a triad: debridement, glycemic control, and antibiotics. The hidden trap that students always miss? Offloading pressure from the foot. It is a vital, totally non-negotiable requirement.
For tetanus, caused by the spore-forming Bacillus Clostridium tetani, your earliest symptom is trismus, or lockjaw. This happens because the toxin tetanospasmin actually blocks your inhibitory neurotransmitters. Crucially, the treatment involves tetanus immune globulin, wound debridement, metronidazole, and supportive care. The trap here, thinking the vaccine alone treats the active disease. It absolutely does not.
Let's move on to Section 2, Systemic and Abdominal Infections, and see how these rules apply to more complex scenarios.
With tuberculosis, test riders love to go after extrapulmonary sites. Cervical lymph nodes are actually the most common one, and when TB hits the thoracic spine, it gets a special name: Pott's disease. For diagnosis, do not fall for the Mantoux test trap. The true gold standard for your exam is culture or a nucleic acid amplification test, like GeneXpert, which sometimes requires histopathology.
Now picture a timeline for typhoid, which is caused by Salmonella typhi. In week 1, early disease is best caught with a blood culture, though technically, a bone marrow culture is the most sensitive. But fast forward to week 3. This is exactly when the highest yield surgical trap strikes. Week 3 is the window for the most feared surgical complication: terminal ileal perforation. Keep that timeline straight in your head.
Let's put two distinct liver infections head-to-head. Hydatid disease is linked to the dog tapeworm Echinococcus granulosus, and it uses albendazole as an adjunct to surgery. On the flip side, an amoebic liver abscess caused by Entamoeba histolytica usually strikes the right lobe. It's primarily treated medically with metronidazole. But here's the trap. You absolutely must follow that up with a luminal amoebicide to wipe out the cysts lingering in the gut.
For necrotizing pancreatitis, E. coli is the most common infecting organism, and that happens directly because of gut translocation. The major trap here is your own instinct to aggressively intervene. Resist it. You must avoid early surgery. The preferred treatment is always delayed drainage or debridement, and only when it's specifically indicated. Patience is literally the right answer here.
Next up is Section 3, Tropical Infections and Rabies, where we'll look at some unique pathogens.
Diving into tropical infections, you'll see every pathogen leaves a really unique footprint. Mycetoma, or Madura foot, presents as a chronic infection with sinuses that literally discharge grains. Leprosy severely damages the peripheral nerves. And filariasis most commonly shows up as severe lymphedema or elephantiasis. But test writers love to trick you by obscuring the fact that a hydrocele is incredibly common in infected men. Don't let them hide that from you.
Rabies is caused by a virus in the lyssavirus family, and the terrifying clinical truth about this disease, it is almost universally fatal once symptoms begin. Because of that grim reality, the exams are heavily focused on immediate prevention, which makes post-exposure prophylaxis absolutely critical.
So following a potential rabies exposure, you must meticulously follow a step-by-step protocol. Step 1 is always aggressive wound washing. You follow that immediately with the vaccine. And depending on the high-risk exposure category, you might add rabies immunoglobulin. You simply cannot skip these steps.
Okay, Section 4, Debatable MCQs and Traps. This is where reading carefully makes all the difference.
You are going to see this exact question all the time. What is the most common organism in cellulitis? Strep pyogenes is the classic answer, for sure. But read the stem carefully. If they specifically describe a purulent cellulitis, the correct answer immediately pivots to Staph aureus. The presence of pus completely changes the pathogen.
Context really does change everything. For instance, necrotizing fasciitis is usually group A strep if it's type 2, but it switches to polymicrobial if the stem describes type 1. Same goes for an amoebic liver abscess. Don't just rush to surgery. Metronidazole is first line. It only needs drainage if the stem specifies it's large, left-sided, ruptured, or failing medical therapy. And finally, while older exams accepted culture for TB diagnosis, modern questions heavily favor NAT, like GeneXpert, for immediate answers alongside a culture confirmation.
We made it to Section 5, High Yield Rapid Review. Let's lock this all in.
Let's recap this rapidly. Staph aureus dominates clean surgical wounds. Pain out of proportion? That's necrotizing fasciitis, strictly requiring emergency surgery. Cephropharynges equals gas gangrene. Trismus guarantees tetanus. And remember, an abscess always means incision and drainage.
Continuing our rapid fire, Pott's disease is spinal TB. Echinococcus granulosus causes hydatidine disease in the liver. Treat an amoebic abscess with metronidazole. Typhoid commonly perforates the terminal ileum. Filariasis leads to lymphedema and hydrocele. And rabies? Universally fatal without immediate post-exposure prophylaxis.
Section: Sutures, needles, and knots. This is the foundation of surgical skills, and honestly, it's where test makers really love to trip you up with material absorption rates.
Let's talk about absorbable sutures first. PDS is your strongest absorbable suture. But the exam trap? Well, students often forget that it actually has a longer absorption time than Vicryl. Speaking of Vicryl, this is your most commonly used absorbable suture. The big trap here is guessing catgut. Test makers love throwing catgut in there. It's a natural absorbable suture, sure, but it causes the highest tissue reaction, so it's really rarely the best modern answer. For non-absorbable sutures, Prolene is your gold standard. It's a monofilament with the absolute least tissue reaction, which makes it the VIP for vascular surgery. And finally, for standard skin closure, you're usually going to see nylon or Prolene, often placed as interrupted sutures.
So, the crucial point here is knowing exactly when to use what. When a question asks you for the best suture for a bowel anastomosis, your correct choices are PDS or Vicryl. But watch out, because silk is a massive exam trap here. You have to strictly avoid using silk inside the lumen of the bowel. Make sure you keep that distinction firmly in your mind.
Now let's look at the actual physics of needles and knots. A standard cutting needle is used for skin, but its cutting edge can inadvertently cut right into deeper tissue. That is exactly why the reverse cutting needle is so brilliant for skin and fascia. It significantly lowers the risk of tissue tearing. A taper needle, on the other hand, is exclusively for soft tissues. We're talking bowel, vessels, and muscle. Never, ever use a taper needle on tough skin. As for knots, the square knot is your basic, everyday surgical knot. But if the tissue is under tension, you're going to need a surgeon's knot, because that extra throw physically prevents the knot from slipping.
Moving right along to Section 2, Instruments and Scalpel Blades.
Knowing the difference between traumatic and atraumatic instruments is pretty much a guaranteed point on the wards. Mosquito forceps are perfect for hemostasis of tiny vessels. But I want you to compare Alice and Babcock forceps. The Alice forceps are traumatic. They're used only for really firm tissue, like fascia or breast tissue. If you're handling delicate structures, like the bowel, appendix, or ureter, you must choose the atraumatic Babcock forceps. Similarly, Kosher and Lane forceps have teeth, so they're meant for tough tissue and skin. You would never use them on something delicate like thyroid fascia. Finally, DeBakey forceps are your atraumatic go-to for blood vessels.
And this brilliantly illustrates how the traumatic versus atraumatic concept applies to scissors too. Metzenbaum scissors are designed strictly for delicate, soft tissue dissection. A super common exam trap is using Mayo scissors for fine work. You wouldn't do that, because Maya scissors are built for dense, heavy tissue. So just remember, Metz for delicate, Mayo for dense.
Let's quickly master scalpel blades. Blade number 10 is your standard workhorse. It's the most common choice for a large skin incision. Blade number 11 has this very sharp pointed tip, making it the only correct answer for stab incisions, like draining an abscess or inserting a chest drain. And finally, blade number 15 is small and curved, which makes it perfect for small, highly precise incisions in hand or plastic surgery. So you know exactly which blade, needle, and forceps to ask for. But here is an incredibly important question. How do we actually ensure these tools are safe and sterile to use, especially the delicate ones, without accidentally melting them into a puddle in the process?
That brings us perfectly into Section 3, Sterilization, Scrub, and Cautery, the invisible but completely critical operative environment.
Let's connect some key time-based facts here. The standard surgical hand scrub duration is 2 to 5 minutes, though keep in mind, alcohol rubs are also totally acceptable nowadays.
Now for arguably the most classic MCQ trap in all of surgery, steam autoclaving. The best method for metal instruments is the autoclave, and you absolutely must memorize the exact parameters. It requires 121 degrees Celsius for exactly 15 to 20 minutes. Test makers will absolutely try to change those numbers to confuse you, so lock those digits in.
Now, what's really interesting when looking at electrosurgery safety is the difference between cautery types. Monopolar cautery is standard, but it requires a grounding plate placed on the patient's body to actually complete the circuit. Bipolar cautery, however, doesn't need a plate at all. Why? Because the electrical current only passes between the two tiny tips of the forceps. This physiological fact means there is significantly less lateral tissue spread, making bipolar the safest, most preferred choice when you're working near delicate nerves and structures.
Back to those sterilization traps. You know the autoclave is for metal, but what about heat-sensitive equipment? The correct answer here is ethylene oxide gas. Do not choose the autoclave. It will literally destroy the equipment. Similarly, endoscopes require low-temperature methods like ETO or plasma, never steam. And here's a really surprising piece of trivia that shows up on exams all the time. If a surgical glove is going to perforate, where does it happen most often? The correct answer is the index finger of the non-dominant hand. Pretty wild, right?
All right, moving into post-operative management with Section 4, drains, tubes, and catheters. When choosing a drain, you almost always want a closed suction drain, like a Jackson Pratt or Redovac, especially after a clean surgery. The exam trap is the open corrugated drain. Because it's open to the outside environment, it carries a significantly higher risk of infection. And remember, the most common complication of any drain is an ascending infection. Therefore, the absolute cardinal rule is to remove the drain as soon as it is no longer strictly needed.
Let's move to chest tubes and see how this builds on anatomy. The insertion site is the safe triangle located at the 4th or 5th intercostal space. But here is the critical life-saving trap. You must insert the tube strictly above the upper border of the lower rib. Why? Well, because the intercostal vessels and nerve, the neurovascular bundle, lie directly below the inferior border of the rib. Going above the rib is literally the only way to avoid catastrophic bleeding.
Nasogastric tube confirmation questions rely entirely on you knowing the difference between best bedside and gold standard. The fastest, best bedside confirmation is checking the pH of the gastric aspirate. However, the absolute gold standard confirmation is a chest X-ray. If there is any doubt whatsoever, you must obtain an X-ray before initiating feeding to ensure you aren't accidentally infusing formula right into the lungs. Pay very close attention to exactly what the question is asking.
For urinary catheterization, the Foley balloon catheter is your gold standard. But please, pay close attention to this absolute contraindication. If you suspect a urethral injury, which is classically presented in questions as blood at the meatus or a high-riding prostate on exam, you must never, ever insert a Foley catheter. Doing so can turn a partial tear into a complete transection. This is a fatal exam trap, so always look for those warning signs in the clinical vignette.
And here we are in the final stretch. Section 5, wound closure and high yields. Let's synthesize this all together. The clinical state of a wound dictates exactly when and how you close it. If you have a clean wound, you close it immediately at hour 0. This is called closure by primary intention. Now, if the wound is contaminated, you leave it open initially, treat the area, and then close it days later once the infection is controlled. This is delayed primary closure. Finally, if a wound is heavily infected, you leave it open for weeks, allowing it to heal from the bottom up through granulation tissue, and that is secondary intention.
Let's do a rapid-fire review of the most critical pairings. You need these associations to be completely automatic. For sutures, Prolene equals vascular. PDS equals strongest absorbable. For forceps, Babcock equals atraumatic for delicate bowel, Alice equals traumatic for firm fascia. For scissors, Metzenbaum equals delicate tissue dissection, Mayo equals dense, heavy tissue.
And here are your super high-yield one-liners. Knowing these cold will absolutely secure you points. Use nylon or Prolene for skin closure. A cutting needle is for skin. A taper needle is for bowel and vessels. A standard autoclave requires 121 degrees Celsius for exactly 15 to 20 minutes. Use ethylene oxide gas for heat-sensitive instruments. And finally, monopolar cautery always requires a grounding plate, whereas bipolar does not.
Traps in medical imaging, specifically what to order first.
In an emergency, examiners absolutely love testing your clinical judgment over just your tech knowledge. Imagine a patient presents with an acute abdomen. You might be super tempted to jump straight to a CT scan, right? It's undeniably more sensitive, but that is a classic exam trap. Examiners actually want to see you start with a plain, erect chest and abdominal X-ray. It's all about understanding those immediate, practical first steps before escalating to advanced imaging.
Now notice how your decision splits entirely based on patient stability. Picture a chaotic ER. A trauma patient rolls in. If their vitals are stable, you go with the gold standard for solid organ trauma, a contrast-enhanced CT, or CECT. But, and this is huge, if that patient is hemodynamically unstable, you never ever send them into the isolation of a CT scanner. For the unstable patient, a FAST or EFAST scan is absolutely your crucial first step.
Let's look at acute pancreatitis over time. Initially, the absolute best investigation is simply checking serum lipase. The trap here, trying to trick you into ordering a CT scan on day 1, don't fall for it. A CT scan is only indicated 48 to 72 hours later, and really only if the condition is severe or the diagnosis is still uncertain. So trust the timeline and always check that lipase first.
Okay, let's walk through some major GI and renal traps. For gallstones and obstructive jaundice, ultrasound is your go-to initial step. Not a CT, and definitely not an immediate MRCP. MRCP is fantastic for detailed anatomy, but remember, it's diagnostic only. For common bile duct stones, ERCP is the gold standard because it's therapeutic. You can actually treat the issue right then and there. Now, pay close attention to appendicitis. In adults, you want a CECT abdomen. The trap is picking ultrasound, which is really only the first step for kids or pregnant patients. And for renal colic, go with a non-contrast CT-KUB and completely ignore that outdated IVU option.
Let's keep this momentum going with a few more high-yield scenarios. Pulmonary embolism? CTPA is your correct answer. A VQ scan is only for when CTPA is contraindicated. For DVTs, we want a duplex Doppler ultrasound, not routine venography. Okay, spinal cord compression. This is a true, literal emergency, meaning an MRI is the immediate non-negotiable choice, just like it is for a disc prolapse. No plain X-rays there. For staging pancreatic cancer, a pancreas protocol CECT is the gold standard, while an endoscopic ultrasound is just for the biopsy. Oh, and if you're hunting for liver metastases, a contrast-enhanced MRI actually beats a CT in sensitivity.
Moving on to Section 2, Decoding Nuclear Medicine, or specific scans for specific targets.
Test riders love blurring the lines with these specialized glowing scans. The absolute biggest trap? The PET-CT. It's incredible for staging cancer and finding occult metastases, but you have to remember it is never used for routine screening. Next, a bone scan is highly sensitive for bone metastases, but it's not very specific. If you suspect acute cholecystitis, but the ultrasound is kind of inconclusive, a HITA scan is your next move. And for renal scans, let's keep them straight. DMSA is a pediatric's favorite for detecting renal cortical scarring, whereas MAG3 assesses renal drainage, function, and obstruction.
All right, Section 3, Surgical Oncology and Spread, Knowing the Pathways.
Understanding exactly how tumors travel is like holding the master key for oncology questions. Here's a classic absolute rule you just have to commit to memory. Carcinomas primarily spread through the lymphatic system. Sarcomas, on the other hand, bypass the lymphatics entirely. They spread hematogenously, meaning directly through the bloodstream, and their most common metastatic destination is the lungs. So, lymph for carcinomas, blood to lungs for sarcomas.
Let's clear up some liver statistics that constantly show up as traps. First, the liver is the most common site of hematogenous metastasis overall, excepting tumors that drain outside the portal circulation. Second, if a question asks for the most common liver malignancy overall, the answer is metastasis, usually from a colorectal source. But, and watch out for this, if they ask for the most common primary liver cancer, meaning it actually started in the liver, the answer is hepatocellular carcinoma, or HCC, not cholangiocarcinoma.
Section 4 already, biopsies and tumor markers, confirming the diagnosis.
Imaging is great, but histopathology is the ultimate gold standard for diagnosing cancer. Let's look at this step ladder of biopsies. Step 1 is FNAC, or fine needle aspiration cytology. It gives you loose cells, but crucially, it cannot assess tissue architecture. So we step up to step 2, the core needle biopsy. This provides actual histology and is the vastly superior gold standard for solid tumors, like most breast lumps. Finally, step 3 is the excisional biopsy. You'd prefer this for small, accessible lesions or lymph nodes, where you can feasibly just remove the whole thing surgically right from the start.
Now, let's lock in some specific cancers and their markers. Hepatocellular carcinoma is tracked with AFP. Colorectal cancer pairs with CEA, but here's the trap. CEA is mainly used for follow-up, not initial diagnosis. Pancreatic cancer links to CA19-9, which, again, is not for screening. Epithelial ovarian cancer uses CA125. Prostate cancer uses PSA, but remember PSA is organ-specific, not cancer-specific, so it can rise in benign conditions too. Medullary thyroid carcinoma is famously linked to calcitonin, super high-yield fact there. And finally, germ cell tumors are tracked using AFP and beta-HCG, depending on the subtype.
And here we are at Section 5, Staging and Treatment Timing, the final steps. The universal language for staging cancer is, of course, the TNM system. T is the primary tumor, describing its size and local invasion. N stands for regional lymph nodes. The massive trap here is thinking N includes distant nodes. It doesn't. It strictly refers to regional ones. Finally, M stands for distant metastasis. If M is present, it almost universally, automatically equals stage 4 disease.
Let's quickly cement treatment timing. Point 1 happens before surgery. This is neoadjuvant therapy. Neo means new or before, and its goal is to literally downstage or shrink the tumor prior to the scalpel. Then, point 2, you have the surgery itself. Point 3, after surgery, we give adjuvant therapy. The goal here is to sweep up any microscopic disease left behind and reduce the chance of recurrence.
Our last key concept compares the extremes of radiation therapy. You have incredibly radiosensitive tumors, ones that basically melt away with radiation, like lymphomas and germ cell tumors. On the flip side, you have highly radio-resistant tumors, famously including melanoma and renal cell carcinoma. And here's a really brilliant clinical pearl for you. When you give chemotherapy at the exact same time as radiotherapy, concurrent chemoradiotherapy, the chemo actually acts as a radiosensitizer. It literally makes the radiation much more effective.
Let's jump right into Section 1, the autoclave and moist heat. So steam autoclaving is absolutely the most commonly tested sterilization method out there, for metals, surgical instruments, and drapes. You're almost guaranteed to see a question on this. But here is where so many students accidentally lose easy points. The exam trap will try to trick you into saying that the high pressure inside the autoclave is what actually destroys the bacteria. Please, do not fall for it. The correct answer is always that the moist heat is what kills the microorganisms. The pressure itself doesn't actually kill anything. Its only job is to raise the boiling point of water. That's what allows the steam to reach those incredibly high lethal temperatures. So remember, heat is the weapon, pressure is just the vehicle.
To actually hit that lethal heat, you have to commit these standard exam values to memory. A standard autoclave cycle runs at 121 degrees Celsius at 15 psi for 15 to 20 minutes. I always told my students to just repeat it like a mantra: 121, 15, 15 to 20. But what if you're in a rush? You drop a crucial surgical instrument on the floor and you need it back immediately. That is exactly when you use flash autoclaving. This is meant for urgent, unwrapped instruments, and it cranks the heat way up to 134 degrees Celsius for a really quick 3 to 4 minutes.
Moving right along to Section 2, dry heat and gas sterilization.
What exactly happens when an item would literally melt in the autoclave? Or when all that steam moisture would ruin it? Well, we obviously need alternative methods. Examiners really love to test your knowledge of equipment types and see if you can match them to the perfect sterilization method. Ethylene oxide gas, or ETO for short, is your absolute go-to answer for heat-sensitive plastics and certain delicate endoscopes. If steam melts it, ETO is your answer. On the flip side, we have the hot air oven, which uses dry heat. Why dry heat? Because steam just can't penetrate oils or powders, and it might damage certain delicate glassware. So strict rule here: always associate ETO with heat-sensitive instruments and the hot air oven with glassware, powders, and oils.
And speaking of that hot air oven, here is the magic number you need to highlight, circle, and underline in your brain right now: 160 degrees Celsius for 2 hours. See, because dry heat is honestly pretty bad at penetrating items compared to moist steam heat, it requires a much higher temperature and a significantly longer exposure time to get the job done. This specific value is a frequently asked super high-yield rote memorization fact. Lock it in: 160 degrees for exactly 2 hours.
Let's move to Section 3, radiation and filter sterilization.
Now, these are physical sterilization methods that completely ditch the heat, and they're used heavily in large industrial and pharmaceutical settings. Take gamma radiation, for example.
It has incredibly deep penetrating power, which makes it perfect for industrial sterilization of prepackaged disposable medical equipment. Think plastic syringes, catheters, and searchable gloves. UV radiation, on the other hand, is kind of the opposite. It has really poor penetration, so it's strictly used for surface and air disinfection. And finally, we've got filter sterilization. This is the go-to for heat-sensitive liquids like vaccines, sera, and liquid antibiotics. Rather than killing the bugs with heat, the tiny micropores in the filter act like a bouncer, physically removing the microorganisms from the fluid.
Next up is Section 4, Disinfection versus True Sterilization. This is a big one. This topic is honestly where so many students get tripped up and fall into a gray area. So let's gently but firmly nail down what these terms actually mean. True sterilization is absolute. It is a process that completely, 100%, eliminates all forms of microbial life. And here's the exact keyword those test makers are hunting for. To be considered true sterilization, a process absolutely must be sporicidal, meaning it has to kill highly resistant bacterial spores. If it doesn't kill spores, it's not true sterilization. It really is that simple. And that brings us to literally the oldest exam trap you will ever face. A question will casually suggest that boiling an instrument in water at 100 degrees Celsius sterilizes it. Nope. The correct answer is that boiling provides low-level disinfection only. Yes, boiling is great for killing off many vegetative bacteria, but it completely fails to kill those tough bacterial spores we just talked about. Therefore, it is definitively not sterilization. The exact same logic applies to pasteurization, by the way. It reduces the number of pathogenic organisms, but it does not achieve true sterility.
Let's pivot to chemical agents for a second. 2% glutaraldehyde is the most commonly used chemical for flexible endoscopes, but pay really close attention to its classification. It's a high-level disinfectant, not true sterilization. Then we have 70% alcohol. We use it all the time, it's awesome for skiing and small equipment, but it is strictly non-sporicidal. And finally, chlorhexidine and povidone iodine. These are skin antiseptics, meaning they are designed for preparing human tissue for surgery, definitely not for sterilizing the surgical instruments themselves.
All right, Section 5, Biological versus Chemical Indicators. Let's talk about proving sterility.
This is, hands down, the absolute highest yield topic on board exams regarding this entire subject. How do you actually prove that your sterilization method did its job? Every single day in hospitals, instruments are wrapped with this chemical indicator tape that magically changes color when it's put through an autoclave. But here's the catch. That color change only proves the item was physically inside the machine and exposed to heat. It does not prove the cycle actually killed anything. To prove true sterility, you absolutely must use a biological spore test. This is the gold standard. If your machine's cycle can successfully kill a test file of the most incredibly stubborn spores on Earth, then you know for sure your instruments are truly sterile. And yes, you are going to need to know the specific scientific names of those stubborn test spores. For the steam autoclave, the biological indicator is Geobacillus stereothermophilus. A great way to remember that is the word thermo in the middle because it just loves extreme heat. But check out the next two rows. Both ethylene oxide gas and the hot air oven use the exact same spore for testing, which is Bacillus atrophaeus. Grouping those two together in your mind right now is going to save you some precious time on test day.
And we have made it to the home stretch. Section 6, High-Yield Exam One-Liners. First off, congratulations on making it to this final rapid review. We are going to take everything you just learned and synthesize it into super clean, crisp takeaways, so you can instantly recognize those correct answers. Look at how steam autoclave, hot air oven, ETO gas, and gamma radiation all get a big, definitive yes for killing spores. Filter sterilization achieves the same outcome by physically removing them. The big takeaway here? If an exam question asks for true sterilization, your answer absolutely has to come from this list. Let's keep up the momentum and rhythmically check off these super high-yield facts. Autoclave means moist heat under pressure at 121 degrees, 15 psi for 15 to 20 minutes. Its biological indicator is Geobacillus stereothermophilus. When the question mentions heat-sensitive instruments, you instantly choose ETO gas. Its biological indicator is Bacillus atrophaeus. When they throw the hot air oven at you, your brain should immediately scream 160 degrees Celsius for 2 hours. Continuing our rapid-fire review, the hot air oven is specifically your go-to for glassware, powders, and oils. Gamma radiation handles the factory-level sterilization of disposable syringes and catheters. Remember our big trap, boiling disinfects, but it does not sterilize.
2% glutaraldehyde is going to give you high-level disinfection for those flexible endoscopes, but again, it's not a true sterilization process. And lastly, 70% alcohol is wonderfully useful in the clinic, but it is definitively not sporicidal.
So, as we wrap up this explainer, I want to leave you with a quick scenario to test your new reflexes. Imagine you are sitting down for your exam tomorrow and you see this. If a delicate, flexible endoscope would melt in a steam autoclave, and we know 2% glutaraldehyde only achieves high-level disinfection, what method do you select to guarantee absolute, true sterility for those heat-sensitive plastics, and how do you prove it actually worked? Well, by now I know you've got this. You use ETO gas and you prove it with Bacillus atrophaeus. You are totally ready to crush this material. Thank you so much for joining me today, and best of luck studying.